Welcome, everybody. We start in 25 minutes.
Gracias, buenos días.
Hola, ¿cómo estás? Radames, ¿es Radames?
Sí, maestro, bien, aquí esperando a que empiece la reunión. Les mando un fuerte abrazo. Aquí estamos. Voy a prepararme un café mientras para estar al pendiente.
Oh, ok. ¿Dónde? Radames, ¿verdad?
Así es, aquí estamos, Tuxtla Gutiérrez,
Oh, mira,
Chiapas.
tu sombrero, qué bueno.
Aquí andamos, maestro.
Qué bueno. ¿Cómo ha estado?
Muy bien, muy bien. Ya sabe, de repente se nos dificulta un poquito unirnos pues, por el trabajo, pero cuando se puede, cuente con nosotros.
Sí, tú tienes buen background.
Ah, sí, Kandinsky.
Sí, muy bueno, pero es real, no es un background, ¿no?
¿Cómo? No, es real.
Sí, es real o
Digo,
virtual.
pues es una copia, ¿no? Pero pues me
Oh,
gustaría
ok.
tener el original, pues.
Oh, ok, pero tú tienes café real, ya.
Sí, pues. Sí, maestro, pues en un ratito aquí estoy al pendiente con el audio.
Ok. ¿De dónde eres? ¿Qué parte de México está?
Chiapas,
Oh,
hasta el
che, qué
sur,
bueno, qué bueno.
pegado a Guatemala.
Ah, sí, nunca he visto. Nunca he visto. Déjame poner mi cámara. Um, espera.
Bueno, pues cuando guste por acá, pues ya sabe que son
Yeah,
bienvenidos.
Chiapas, yeah, cerca de Guatemala. Yo estoy cerca la aduana de Honduras y Guatemala, en la
Ajá.
parte caribeña. Muy rural, muy rural. Es,
Ok.
eh, es jungle,
Ujú.
allá.
Sí, exactamente, toda la selva lacandona está por acá, toda esta parte, lo que
Sí,
tiene que ver con
no hay,
Chiapas,
no hay
Campeche,
ciudades.
Tabasco, Yucatán, Quintana Roo, donde está Cancún, todo esto. Por acá cerca
Sí,
estamos.
sí, sí,
Y
pero
ahora que tengamos,
Chiapas parece bonita.
sí, es muy bonito, y ahora vamos a tener el Tren Maya para que se dé una vuelta por toda la península.
Ay, qué bueno.
¿Sí?
Ok, empezamos en 25 minutos, ok?
Perfecto, claro que sí, maestro, lo veo en un momento. Gracias.
Ok. Hey, Sam? Are you in there?
Yes, I am here.
Okay.
How are you,
How you
Tom?
doing?
I'm fine. What about you?
Good. Changing my background. They dress casually, huh?
Yes, yes.
Okay. Everybody
John.
likes a train wreck.
Hello, John. How are you?
Hello, Jorge. Good. Welcome.
Thank you. Nice to see you again.
I see you. You know Sam, right?
Yes. Nice to see you.
Nice to see you, Professor Jorge.
Yeah, they have an active Ecuadorian meeting on Tuesday night. Not Tuesday night, Friday night. Friday night.
Yeah, last night we had.
Yeah,
a
you're a
lecture.
very active group.
Thank you very much for your assistance, John.
Yeah, it's fun. It's fun when when it works. It's fun, and it works with you guys. There's participation, and Brian. I like the way Brian is. He's aggressive. He asks people questions and says, "What do you think of this?" It's not just letting it go. He gives it direction, which helps.
Yeah,
Like
it's
Sam's
very
going to do
nice.
that today, right, Sam?
Yes, John.
Mira, compañero de México, Radames, hola.
Hola, buenos días, aquí estamos.
Dr. Salazar. Mira cómo está vestido, Jorge. Su
Hello.
sombrero.
How are you?
Sí, es
Can
una
you see
pequeña
me?
fijación por los sombreros que tengo.
Sí, la gente piensa en México. Oh, Said.
John, you cannot see me.
Oh, yeah. Your
Hello.
camera's not on. I don't know what's going on. Can you turn your camera on?
No, I cannot. I don't know what's going on.
Deca maybe. Okay. Necesita deca entrar. Tú necesitas un panel.
Okay.
Okay. What about today? Said, how you been?
Fine, and you?
Good. Are we gonna do the French grand rounds anytime soon?
Yes, maybe in two weeks.
Okay, let me know. Let me know.
Okay.
Hello to everyone. Greetings from Ecuador.
Hello, Professor Yo. How are you?
Nice to see you. Fine, fine.
Fine,
You're
thank
doing a
you.
great job.
Yeah. Dr. Samir,
Dr. Said, how are you?
fine, fine. Ahlan wa sahlan.
Alan Vic. Thank
It's
you for
okay.
joining us today.
Thank you very much. Thank you very much. It's a great pleasure.
So you got to hold the speakers and everything, Sam?
I am just recalling.
Oh, I
some-
gotta make you the co-host. I didn't make, hold on. I'll make you the co-host too, Syed.
Hello, Sami.
Professor Sushi.
Yeah,
How are
can
you?
you hear me?
Yes,
Good,
I
thank
am.
you. How are you?
I'm fine. Thank you for joining
Great,
us.
great. No, my pleasure. Can you see my face?
So
No.
let me
No.
let me get you in, Sochi. Oh, I don't see you in.
I hope you can see my face.
Oh, there you are. There you are.
It's
Hi.
okay now. It's
Looks
okay
good?
now.
Yeah, we can see you.
Okay.
Yes, it's okay. How are you?
Great. Hi, everyone.
Hi.
Hi, Professor Soji.
Hi. I'm Soichi from Japan. It's almost 0 a.m.
Yeah, that's right, midnight. The bewitching
perfect
hour.
time to right, perfect time for making presentations.
Thank you.
We have Professor Ohada too, right?
I don't see him.
Hi, James.
Hey, Soichi.
Hey, how are you?
Good to see you. It's been a long
Good
time.
to see you again. Right.
So, Same, Soichi and I were both in Cairo in 2016 together.
Yeah, I have.
Yeah.
I have got your photo there. It's
Yeah.
now
you-
on my phone.
Yeah. We enjoy the camel riding.
Yeah.
We hope to see you again soon.
Yeah, no, looking forward.
I am trying to reach Professor Ohata. Unfortunately, he doesn't respond. So I think we will start with Soichi.
Okay.
Nice to see you, Professor Lee.
Okay, just 2 minutes to start.
Yeah, 3 minutes, Sam, about that, about 3,
Okay,
okay. I'll just introduce you, you run the show, right?
yes, as usual, my dear friend.
Yeah. And I don't know, what are you gonna, I guess, take each speaker at the same time and have questions after, or how are you gonna work it, Sam? Have them present, how you gonna work it?
25 minutes for lecture, then
Oh.
5 minutes afterwards for discussion.
Okay, after the presentation, you're gonna have, you'll just tell the audience what you're gonna do. Questions
Yeah.
after or wait to the end, right?
Okay.
Whatever you wanna do. Sam, the name of the conference, what are you gonna call it? Worst neurosurgical scenarios that we have faced? Is that correct?
Yes, it's okay.
Okay,
It's according to our series. It's a second session of most remarkable lessons from OR.
which one should I use there, Sam? Well, I use the worst clinical neurosurgical scenarios. You ready to start, Sam?
Okay. As you wish.
Okay. I'm sorry?
Okay, as you wish.
Okay, here
Go
we go,
ahead.
Sam. Here we go, Sam. 10, 9, 8. Good morning. Good morning from Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV. We are honored with the presence of Samuel L. Morsi and the EWNC. In collaboration with us, we're going to present the conference today. Very interesting sounding conference. Worst neurosurgical scenarios that we have faced from some top neurosurgeons from around the globe. And I'll turn the proceedings over to the inimitable Samuel L. Morsi. Good day, Sam.
Good day, John. Thanks a lot, dear friend, for your presentation. Dear friends, it's time to second lesson from OR. Most remarkable lessons from OR, lesson 2. The worst scenario that we ever face. And we will start with Professor Soichi from Japan. Please, sir, start sharing your screen. Thank you.
Okay, Sam, I'm going to share my screen. Let me see. Does it look good? Look good?
Yes, it
Yes.
does.
Okay. Okay. Hi, my name is Dr. Soichi Oya. I'm from Saitama Medical University, Japan. I'm very much honored to be able to, join this meeting. I'm kind of feeling that there is an atmosphere in my country in which we cannot, talk about the serious surgical complications openly, frankly. This is especially so if it comes to serious complications. But I think it's important for surgeons to share our experience and not to repeat them ever. And so I think I agree with the concept and the purpose of this meeting. So today I'm going to present a case of a giant anterior crinoid meningioma. The patient was a 47-year-old lady who had a seizure, and she had no visual deficits and no paralysis. And during the examination, she was found to have this large, huge anterior cranial meningioma, measured as 6.7 centimeter in size. And it was accompanied by the mild edema on the temporal lobe. And the T2 intensity showed, some sort of a firm tumor. So we need to assess the location of the cause of the ICA. So as you see here, this is the Petrus ICA. And as you see here, this comes up like this. And the tumor severely compressed the ICA. However, it did not, encase or engulfed significantly of the ICA. Then we performed the preoperative angiography, and this angiography showed the stretching and the narrowing of the ICA and the M1 and A1, which are the basal arteries. And here you can see how the narrowed the M1 portion. And in the previous literature mentioned that these are the dangerous type from the standpoint of saving the ICA during surgery. And also there was no cross-flow via the ACOM, and there was little cross-flow via the PCOM. So let me see. Let me talk about the rationale for the surgery. This was a huge tumor in a middle-aged patient, so we need to do something to prevent the anticipated symptoms such as the hemiparesis or the disturbed consciousness. And we also hope to control her seizure. So setup and equipments. We chose the supine position and the right large frontotemporal craniotomy, and we use a cruiser, and also we utilize the transcranial motor evoked potential monitoring and visual evoked potential monitoring, Doppler sonography. And in the beginning of surgery, we determined to preserve the superficial temporal artery for possible use of the bypass. So this is the video of actual surgery. In the beginning, I did the extensive drilling of the hypertrophied supinoid bone. Now I'm flattening the anterior cranial base. As you see here, the intracranial tension was really high because of the tumor. However, if you efficiently drill this hypertrophied supinoid bone, you can create enough space for you to work to do the extradural anterior cranioidectomy. And before I open the dura, I always cut the dura around the optic nerve sheath to relieve the pressure onto the optic nerve. Now I open the optic canal. As you see here, this is the optic nerve. And then I open the dura. And at this point, most feeders have already been cut, coagulated during the extradural work. So I didn't encounter massive bleeding from the tumor. So I just, continue to do the internal decompression like this. As we all know, it is very important to control bleeding during the meningioma resection. And I also like to use the cruiser for internal debulking because it is efficient and also safe. And because I didn't have much bleeding, so I could see clearly the vessels like arteries and veins surrounding the tumor. Now I'm looking for the MCA branches. It should be coursing along the tumor surface. And I moving the remaining tumor into the space created by internal decompression like this. I'm just showing you this scene, internal decompression, because I was kind of trying to be very patient and also careful in removing this huge tumor. Sometimes it's very firm like this, but however, everything was under control, I thought at this time. Sometimes you may encounter a kind of active bleeding like this from the tentorium. And I know some centers preoperative feeder embolization frequently applied but utilized, but I don't really use it because the feeders from the tentorium via the tentorial artery can be controlled easily by simple bipolar coagulating. If we ask our endovascular surgeon to do this part, I think they have to take a risk to injure the cranial nerves. Then now I just proceeded with the internal decompression like this. And also, I like you to take a look at the how I use this thick carotenoid. This is very useful instrument because it's heavy, so it covers the brain surface, and also we can obtain the hemostasis. And also we can use the thick carotenoid as a spacer. Now I find some sort of a feeder. It probably used to be functioning as a cortical artery, but now it turned to be our feeders to the tumor. So I confirmed there is no defect of the cortical artery by the ICG video angiography, and also utilized MEP, and I cut this artery. This is the inferior trunk of the M3, but I had cut the branch, one of the branches of this thick artery. But there was no change in the MEP, so I just applied the microhemocrypt, and I cut this MCA branch. So the MEP monitoring was also very effective. Transcranial MEP monitoring is enough to perform this type of surgery. And now the residual tumor became smaller and smaller. And now I have enough space to inspect the portion around the optic nerve. So now this is a tentorium. Now I'm detaching the tumor from the dura around the tentorium and the oculomotor nerve. Again, I was trying to be very careful because I know this tumor was, attaching to the ICA in the deepest area. Then I just repetitively perform the internal decompression. So this is the crystal gully. So you see, this is the place I cut, the optic nerve sheath, and this is the optic nerve. Now I finalized the procedure of detaching the tumor from the tentorium. See, this is the oculomotor nerve. which showed some sort of a redundant course because of the severe compression by the tumor. So the oculomotor nerve was preserved. I put the hemostat so that I can prevent the bleeding, going into the deep area. This is the optic nerve and also the ICA. Now I'm carefully dissecting the tumor off of the optic nerve. So as the dissecting goes on, gradually the thin nerve is becoming thick again. And also I'm checking the amplitude of the VP because she had normal vision, so we need to preserve her vision. And now the tumor, it was almost detached from the base of the dura. You see, this is the last part. I'm detaching the tumor from the dura around the posterior crinoid. And I was careful, I thought at this time, I was careful. And I'm removing the tumor, near the ICA. And I thought I was careful at this time. However, now that I think of it, I think that I may be moving the tumor too much. And I'm feeling kind of the tumor is firmly attaching to the wall of the ICA. So I moved from here, the dangerous part, to the part where I think it is safe. And while I was removing the tumor here, I had bleeding from the ICA. I guess that because this tumor was completely detached from the dura, so I might have moved the tumor too much. So I applied the clip to the ICA, and I like to examine the point of bleeding. However, as you see here, this wall was very vulnerable, so I made the situation worse. So I could not control the breathing at this point. This is a breathing, the backward, from the IC, from the A1 and M1. So I put I have to use the multiple clipping methods to control the bleeding in a blind fashion. And I could finally stabilize this situation. And I now went back to the M1, and I'm following the M1. And this is A1, this is the IC top. So I try to get the distal portion of the ICA, C1 portion, and apply the clip here. So I trap the ICA. But as I expected, there was no sufficient flow via the ACOM. So I have to remove the tumor together with the ICA, the portion the tumor embedded. The whole tumor was removed. And I exchanged the clip from the temporary clip to the permanent clip. And the MEP was gone, but I quickly harvest the STA and perform the STA-MCA bypass. Although I know that the hemispheric cerebral flow will not be supplied by the low flow bypass. Okay. Well, this was non-dominant site, so although she had a hemispheric stroke like this, and she required external decompression on POD1, however, she tolerated very well, and she had left side hemiplegia and consciousness, which was mildly impaired. However, on day 12, she had an AMI, and she expired. I have to assume that the too excessive, the post-operative stress might have caused this complication. So these are the lessons I learned. The previous literature say that narrowing and stretching of the basal arteries indicate the high risk of tumor invasion, adhesion to the arterial wall. Of course, I know this as knowledge. However, I might have not fully understood until it actually occurred. So I learned that it is important. It is impossible to evaluate fully correctly, based on the preoperative imaging studies. So we have to operate on the assumption that this is a real possibility. And I've never experienced this. And so we should always keep an eye on the whole working space. I thought I was safe. I was working in a safe area, but I was moving the tumor too much. So the bleeding occurred. So we have to make sure there is no excessive force on anywhere in your working field. So also I need to learn steps to be taken when ICA injury were actually to occur. So this is ICA A1 and M1. What I did in the surgery was to look at the hole first. However, it made the situation worse and worse. So possibly I should trap the ICA fork first without looking at the hole. Like I put the clips to the ICA M1 and A1, and then resect the tumor from the safe portion, I mean M1 and A1, following the healthy wall. Then look at the hole and examine what I can do, such as suturing or doing the interposition graft. And also we have to prepare for the worst. Although I prepared the the superficial temporal artery, however, it's not sufficient in this case. And I'm not sure about the necessity of the harvesting the radial artery or saphenous vein graft. It's not practical to prepare them in all cases. And also we cannot prevent the perforator infarction of the perforators from the ICA, PCOM, or anterior choroidal artery. So this is how I do now for this type of large or huge anterior crinoidal meningioma engulfing the ICA system. What I'm going to do first is the same. I just examine and evaluate the severity of the adhesion like this. And this is the anterior choroidal artery. And now I realize that this tumor is not amenable to a simple resection. So I do not hesitate to leave a small portion of the tumor behind the ICA. Like this patient, he returned to a normal, his normal life, and the residual portion showed no regrowth for 2 years. So these are take-home messages from me. In resection of anterior crinoid meningioma, you need to, carefully examine the narrowing and the stretching of the IC M1, A1, but you really have to understand, and you really have to do some practical measure to prevent this type of very serious injury. However, it's not possible to evaluate 100% correctly. So you need to be familiar with the steps to be taken when the ICA injury were to occur. And also we have to prepare for the worst, such as the vascular reconstruction. And in meningiomas with a possible adhesion to our major artery, we should avoid too much mobilization after the tumor is separated from the attachment. Thank you very much.
Okay, Sam?
Thanks a lot,
Sam,
Professor. I'm here. Thanks a lot,
Okay.
Professor Soichi, for this excellent presentation. And my question, is there any role for gamma knife in these difficult cases?
Yeah, of course. Sometimes we need a gamma knife after surgery, but probably most of us know that almost like 80 to 90% of this type of tumor do not require post-operative gamma knife in the first 4 or 5 years. I'm not sure after that, but most tumors are histologically benign. I mean, in most cases.
Okay, is there any question from panelists?
Yes,
There's
I
a-
just
there's a
wanted to
comment,
make,
Sam,
I just wanted to
from,
make some comments.
Okay.
Soichi, thank you for sharing that case and your experience. I really appreciate your honesty in sharing this type of case, because I think many of us have encountered very similar situations like that, and very difficult to navigate. And I appreciate your lessons learned that your wisdom that you shared upon us, and how you've changed your practice so that you can avoid that. My question is, when you first inspected the hole, did you think you could do a direct repair of that hole, or was it too big, or were there other considerations such as a muscle patch, or sometimes I've used a taco seal I had an A2 injury and a PCOM injury, but the hole wasn't as big as yours, but I was able to use taco seal to stop the bleeding as something. I was wondering if you had any experience with that as well.
Mhm. Well, what I was thinking at the time was to directly repair, I mean, the suture, the hole. However, the wall of the artery was much more fragile, than I expected. And just removing or peeling the tumor or moving the tumor covering the ICA, enlarging the hole, the bleeding, and I lost my way. And next, my second plan was to end-to-end free graft. I mean, like the SDA, I'm not sure, or radiology graft, to replace the damaged part of the ICA. However, in that case, I cannot save the perforators. So this was on the right side. So I just kind of, abandoned to preserve the motor function of the patient. I was trying to, I was hoping some miracles occur. However, the situation was like this. The result was very bad.
Dr. Samay, I'd like to make a smallish comment.
Okay, you go.
Thank you.
That was a very, very difficult and very formidable case. There is no question about it. These cases are, requires the highest degree of neurosurgery, highest degree of understanding of the tumor, and absolutely highest degree of understanding how much to remove and when to stop. Because from a very,
Right.
very, very fantastic outcome, you can have a zero outcome if you damage one vessel. And you know what? These are the most complex neurosurgical cases. There is no question about it. And I am wondering, in this case, you had even one smallish artery where you had applied a clip and your MEPs were normal at that time. But even the deficits might be due to that vessel. You never know, that vessel may itself be a cause. So what the problem is, in these tumors, you have to preserve each and every small little perforator. You cannot damage one perforator. If you have damaged one perforator, you can have a very big hemiplegia at hand and loss of consciousness and all those things. So these tumors, this was a very, I will compliment you on taking this operation, and I will compliment you on removing this tumor completely. That is one fantastic, and I am sure you are a great, beautiful, fantastic surgeon. There's no question in my mind and no doubt in my mind. But the lessons that you have learned and the lessons you have given to the world of neurosurgery is that do radical resection within the limits and premises of safety. If there is any kind of danger, even a smallish little danger, just leave these tumors. These are not aggressive tumors. They will not, even Samay said about gamma knife, there is no need to do anything for the residual tumor, even if it is 30% left or 40% left. There is no, this patient had hardly any deficit, just convulsion. There was no vision deficit. There was nothing. You could have left 50% of tumor without any problem for next 10 years and 15 years. So this is a beautiful case for, where you have shown your technical expertise, you have shown your complication, and you have given a very beautiful message. So congratulations to you. And I'm sure many of us have learned from your case. Thank you.
Thank you for your valuable comment. I think I should have emphasized that the goal of the surgery or purpose of the surgery, and that we are treating patients, not treating the images. So yeah, thank you very much.
Is there any question from panelists? Thanks a lot, Professor Soichi.
I think,
Thank you.
Sami, I think all these tumors,
Okay, Professor Kiki.
for all these tumors, it is, I think this was an excellent demonstration of a typical great skull-based microsurgery. But for all these tumors, one has to be ready for a bypass right from the beginning. It has to be a part of the plan. You cannot decide on it afterwards. And sometimes it is necessary to do it, prepare everything, and then get on with the tumor excision. So preparation, both mental and physical preparation for a bypass is a must for these skull-based tumors which are invading the ICA complex, in short.
Thank you very much. That's an alternative plan we have to think about, But to completely, restore the hemispheric, blood flow, I think the low flow bypass might not be sufficient. So it was not in my plan to do the SDMCA bypass before removing the tumor. So it was just a kind of an insurance in this case. However, I have to, I have to use the insurance, unfortunately.
Any more comments? Thanks a lot, Professor Soichi, for this excellent presentation and discussion. And
thank you very
I'm sorry
much
for making you too late in Japan. Thank you.
It's okay.
Okay. And now we will shift to the next speaker, Professor James Liu, my dear brother. And I'd like to thank him for her efforts in putting this webinar together. Please, Professor Liu, start sharing your screen. Thank you.
Okay, thank you. Let me find my presentation here. Okay, can everyone see my screen?
Yes.
Okay.
It's okay.
All right, great. Well, thank you, Samay, for organizing this. I'm glad Kiki is here. Kiki is the international host of what I call an international M&M conference, and it's been nice to be involved in those as well. And I think this topic of complications is very important. It's something we probably don't talk enough about. And when putting this together with Samay, we often will show like our greatest triumphs or our greatest saves. And I thought this would be a good opportunity where we show our worst disasters, because it happens to all of us. And we have to be able to learn from them and become better surgeons. I think most of you know this quote from René Leriche. Every surgeon carries within himself a small cemetery where from time to time he goes and pray. And today I will share with you two cases that I hold dear to my heart, and these are two from my own personal cemetery. This is a 55-year-old female who presented with this pineal mass and hydrocephalus, and we initially did an ETV and a biopsy that came back positive for pineocytoma, and she initially did not want any further treatment, and some time was lost due to pandemic, and interval imaging showed that the tumor had grown and causing more mass effect. So our recommendation at this time was to go ahead and remove the tumor. And of course, we had considered various surgical approaches, including anterior interhemispheric, occipital transtentorial, and the approach that I eventually decided on was supracerebellar infratentorial in the sitting position. And so we here's the video showing the surgery. This is the sitting position here. And standard supracerebellar approach, fairly initially unremarkable. So we access the supracerebellar corridor, open up the arachnoid over the quadrigeminal cistern. I try to be careful in terms of the veins. I try to preserve as many veins as possible. Occasionally you have to take one precentral cerebellar vein, which we did here, and then open up the arachnoid to get into the tumor inside the cistern, and then preserving these small perforators, arterial perforators on top of the cerebellum. During the surgery, early on, before even the tumor removal, we did encounter a drop in the end tidal CO2. So we had a precordial Doppler monitoring of end tidal CO2, as well as SSEP and MEP. And in those brief moments, we flooded the field with irrigation. We stopped the surgery for the time being, and then the end tidal CO2 came back up, and so I went on to proceed and continue with the surgery. There were no changes in hemodynamic, blood pressure, or O2 saturation, so we went ahead and proceeded. The drop in end tidal CO2 happened 2 additional times during the surgery, and again we stopped what we were doing. We flooded the field with saline. We put the head in a little bit of Trendelenburg, and after some time, the patient's end tidal CO2 came back up, and we went ahead and proceeded with the surgery. So I won't belabor the point here. I'll just demonstrate a few portions of the video here. But the tumor was relatively soft, easy to debulk. There wasn't really any significant considerable bleeding. All of our neuromonitoring remained stable, so we felt that the surgery was going very well. And just devascularizing the tumor, very small arterial feeders wrapped around the tumor, carefully, sharply dividing them. And then coming around the lateral portion of the tumor as we enter the posterior third ventricle, you can see we want to preserve all of the venous structures and small perforators that usually come from the medial posterior choroidal vessels. So we're peeling the arachnoid that's investing these small perforators to come around the tumor. and eventually we'll get to the anterior portion of this tumor here. And then we come from the bottom side of the tumor. And then using microforceps, where the tumor can become adherent to the ependema of the walls of the posterior third ventricle, we can use these fine microforceps and these bicol sponges to act as spacers, and then eventually work around the tumor circumferentially. And then this is the last view of the resection cavity. You can see this is the posterior third ventricle. There's still some remaining tumor that we're dissecting away, and then cauterizing these last perforating vessels attached to the tumor here. And then this is the last component. You know, from a technical standpoint, I felt that everything was going quite smoothly. Everything had remained stable during the case. But again, like I mentioned, during the surgery, there were these 3 events of a precipitous drop in the end tidal CO2, and we stopped the procedure and copiously irrigated the field. She did have some brief O2 desaturation during the surgery, which the anesthesiologist felt it was, you know, some hyperactive airway treated with albuterol. And at the completion of surgery, when we were trying to extubate the patient, she was having some frothing at the ET tube and O2 desaturation. And so we quickly tried to stabilize the patient. We got a chest x-ray, and you can see there's considerable pulmonary edema here. And so we brought her to CT. We got a CTA of the chest, which was had some subsegmental pulmonary embolism, and then a CTA of the head that did not show any strokes or venous occlusion, but her exam was quite poor. She was not opening eyes, not following commands. Pupils were sluggishly reactive, didn't have any great brainstem reflexes or motor response. This is the post-op CTA. The venous anatomy was relatively intact. We did not see any venous air bubbles in the venous system, but nevertheless, my suspicion was that this was probably a sequela of venous air embolism. And the next 24 hours had gone precipitously bad. She was severely acidotic. She had a poor echocardiogram and terrible blood sugar control. And she went into multi-organ failure. And when we started dialysis for worsening renal function, her blood pressure precipitously dropped from the hemodialysis, and unfortunately she went into cardiac arrest without successful CPR. So as you can see, this was a terrible disaster. My conclusion was that this was a complication of venous air embolism, and as you know, this is a known complication after using the sitting position for this supracerebellar approach. Some of the lessons that I think I learned from this after undergoing some critical self-analysis is that my positioning should be more modified into a more semi-sitting position where you elevate the legs higher than the heart. Transesophageal echo, I think, is important to consider in addition to monitoring end tidal CO2 and precordial Doppler. It's important to wax all of the bone edges. Sometimes you can aspirate air from the bony openings that you don't see, because in the sitting position you don't see the bleeding. In retrospect, we did wax very carefully, so I'm not sure where the air was sucking, but I think in retrospect we can also use jugular venous compression to see where the source of bleeding is from, so that we can address where the source of air sucking is coming from. And something that I had thought about was, could I have, just stopped the surgery when the end tidal was dropping, and then come back on a different day, when I ensured everything was stable. And it was a tough decision, because these drops in end tidal CO2 were happening even before the tumor was even exposed, and even before tumor debulking. And the other thing is, perhaps I could have considered alternative surgical approaches that I had mentioned before that could have allowed me to access that region as well. So all in all, this was a difficult case, a difficult lesson. These are just some general things to consider. Anesthetic concerns when you're doing sitting position. From an anesthesia perspective, you can keep the venous pressure high with increasing PEEP. Avoid nitrous oxide, and TIVA anesthesia is preferred. These are some other things that you can use as well in sort of thinking about venous air embolism. The incidence can be up to 16 to 86% when you're using the sitting position. And of course, the pathophysiology here is that this resulted in ARDS and eventually multi-organ failure for this case. So that's the first case I was going to show. The second case is a 56-year-old male who presented with a giant pituitary adenoma, and he was going blind from this tumor. This is the initial MRI that was performed the year prior, and before then he still had some remaining vision, but he was refusing surgery at that time and left the hospital. And a year later, the patient came back with blindness in one eye on the left, and normal, some remaining vision in the other eye. But you can see this is a giant invasive multilobulated adenoma wrapped around the ACOM complex going into the lateral ventricle with hydrocephalus. So we ruled out a prolactinoma. This was a non-functioning tumor. You could see the pre-op visual exam. He was unable to count fingers in both eyes, and able to see some light and shadows. He was having considerable worsening vision. And so in terms of my operative plan, I debated for some time which approach to use, whether I come from below first and then combine it with a craniotomy as a single stage or second stage procedure, or coming in from a craniotomy first as the sole procedure or as a stage procedure. So I eventually decided on coming endonasal first. I felt that I would get a good decompression of the optic chiasm, hoping that the tumor was soft, and then coming back second stage for a craniotomy. So here's the operative video using an endoscopic endonasal approach. Here we are opening the dura, and then here you can see the tumor appeared very soft, very suckable. Typical adenoma. Using standard ring curettes, curetting out the tumor. And here you can see this is the beginning of the right cavernous wall. And then I encountered some venous bleeding here. I believe this was coming from the venous plexus around the cavernous carotid artery. And I wanted to just expose this area better. I'm using a high-speed drill here just to shave some of this bone. And now I encountered this arterial bleeding here. So you can see this is a high flow arterial bleed. This is coming from the carotid artery, and in retrospect, this is coming from the right paraclival carotid artery, and it was in this area of bone that I thought was just part of the sphenoid face, and you could see the drill was involved with the injury here, and so I was able to stop the bleeding with packing it off with cottonoid, and proceeded to debulk more tumor. Here's the membrane of Lilliquist. Patient here was hemodynamically stable, and so at this point I was gonna just repair the sella and go to angiogram. And in here I'm trying to, we've harvested an autologous crushed muscle, and I wanted to seal off this area with crushed muscle so I can seal off the area of opening. But yeah, every time I tried to put the crushed muscle over the side of the injury, the blood would just come out extremely fast, and it resulted in considerable blood loss and hypotension, and so we had to quickly pack this off again. You can see where it's coming from. I think it's important to gain control and to identify what kind of injury it is, whether it's a small pinhole or if it's a large pinhole. But here we are, we've placed the muscle graft over it, and holding some Surgicel over this region. And you can see it's still bleeding through the muscle a little bit. And every time I let go of pressure, the bleeding would start again. It seemed that before the cottonoids did a better job of keeping the bleeding stopped, and so ultimately I just decided to pack off the nose and use some Vaseline gauze and lots of cottonoids. So at this point we took the patient down to angiogram, and you could see here, sorry, this video is not playing, but there was a pseudoaneurysm you could see coming from the paraclival carotid, and my endovascular colleague was able to repair this with the pipeline stent, but they have to use dual antiplatelet agents with aspirin and Brilinta. So the patient now is fully aspirinized, and the post-op CT showed this. You could see there's a lot of considerable remaining tumor, and now it's become hemorrhagic and apoplectic with hydrocephalus. So it was difficult for me to want to place a ventricular drain at this time due to the risk of hemorrhage. So we decided to just put him in the ICU and monitor him. And at that time, his pupils were still reactive. But unfortunately, the following day, he blew and had fixed and dilated pupils. And at that time, we emergently placed the EVD. The pressure was a bit high, and then his pupils improved, but the patient remained hypotensive and had a poor exam, and he eventually did very poorly and progressed to brain death. And so what are the lessons learned here? Giant pituitary adenomas can be quite treacherous. They're defined as tumors that are greater than 4 centimeters. And so if you leave considerable residual tumor, they're at very high risk of developing postoperative apoplexy. And there's certainly well-documented cases where that apoplexy can result in brain herniation and mortality. ICA injury, obviously the best is to avoid ICA injury. I think this is something I could have avoided. I probably didn't have to drill that region to get additional exposure. And, if you do encounter it, crushed muscle can be helpful in stopping the bleeding. And you have to maintain hemodynamic stability and then take the patient to angiogram when the patient is stable to assess the injury and to see if you can either sacrifice the carotid or preserve it with a stent, a pipeline stent. Some of the questions that I asked myself was, could I have placed the EVD before the angiogram, before the patient was on dual antiplatelets? I think that's something I could have considered. Probably could I have debulked more tumor through the craniotomy instead? Unfortunately, the patient was hemodynamically, initially unstable from blood loss, but once we were stabilized, I felt the safest thing was to go to angiogram instead of proceeding with more tumor debulking. And perhaps in retrospect, I perhaps could have considered doing a transcranial approach first. Of course, hindsight is always 20/20. This is Bill Caldwell's recent series of giant pituitary adenomas, and these are very challenging lesions that may require multiple modality of different approaches. And as Dr. Caldwell reported, apoplexy can occur, and unfortunately one of those apoplexy cases resulted in mortality as well. In terms of carotid injuries, these are some of the factors that have been identified in terms of contributing to vascular injury. Of course, power tools, sharp instruments are high risk, and it's something that we have to always be aware of and be mindful of when we're doing any endoscopic or open surgery. Thank you again. These are my cases. I'll be glad to take any questions.
Thanks a lot, Professor Leo, for this excellent presentation. And that two cases that we have learned a lot lessons from it. I see Professor Marcus want to ask something. Go ahead, Professor.
Hey, Jim, how are you? How everybody? Wonderful to be part of the panel. Jim, I hate the. I'm sure I'm going to get some people angry on the panel. I hate the sitting position. I haven't used it in years. I really can do a similar job with the Concord position, getting CSF out. It's more comfortable for the surgeon, for the assistant. And I quit doing midline supracerebellar infratentorial. A lateral paramedian approach, of course, on the flatter end of the pons is all you need, even if you're going to a midline lesion. That's my comment on that first case. The second case, it's tough. When I've had intra-op arterial injuries on various things, tumors or something, and the blood is too much, sometimes to actually see the whole adenosine 30 milligram. I remember doing it years ago on a giant acoustic when I tore the ICA. I wish I had that video. I don't have it. The ICA was on the other side of the acoustic, and I didn't want to bang the facial nerve. So I gave adenosine, gave me just, few seconds to actually see the hole, fix it. And, sometimes these carotid injuries transsphenoidally, just to quickly see the hole, understand what you need for it. I recommend 30 milligram of adenosine. But of course, that's tough cases. Great job.
Thank you, Jacques. Yeah, I agree. I mean, since that case, I think I've shied away from sitting position. I've done most of my pineal, posterior, third ventricular lesions, interhemispheric, lateral position, and I'm able to get there, just fine. So, but yeah, I think it's incidences like these that make you modify your practice somehow so that you can try to avoid the same issues.
And as you said in your comment, the big proponents of the sitting position like Ugur Toure and Marcos Tatajiba, I think they don't use the word sitting position. They use the word slouching position. As you said, legs, yours was really sitting, legs above the head, as you mentioned in your slide. I'd say Concord beats sitting position any day.
Thanks a lot, Professor Marcos. Is there any question from panelists? Thank you, Professor Leo, for this excellent presentation. I have learned a lot from these two cases, and you have concluded a lot of lessons for all of us. Now we will shift to next speaker, Professor Piki Tuel. Please start sharing your screen. Professor Tuel.
Screen.
He's there, Sam. He's
Yes,
there,
yes.
Sam, but he may have stepped away.
I'm
Atul, are you
just
there?
trying to share the
Okay.
screen.
Okay.
He may have stepped away from his computer.
I am on the computer and near. So
Where do you want to go, Sam? Atul has stepped away, I think.
I'm already on the. Can you hear me?
Yes,
Yes.
it's okay. We are waiting for your screen.
Yeah. Can you see my first slide?
Not yet.
No?
Not yet.
Is it visible now?
No, you got to click on the share screen button first.
Screen
That's the
broadcasting.
first thing you have to do. You're not clicking on the share screen button.
Share screen.
Yeah, I can't. You're not sharing it.
I'm share content screen. We are already on it, and then it shows start broadcast, screen broadcast.
It doesn't show you sharing the screen at all.
Start video. Are you seeing me now?
Not yet.
Not yet. Oh.
As soon as you click the share screen button, I should see it, but I'm not seeing that at all. So you're not checking on the share screen button.
Share
First.
screen. This
At
is
the
share
bottom
screen.
of the screen, share screen. Click on that button first.
Some problem. Give us 5 minutes, 2 minutes. Arjun, can you give us 2 minutes?
Give me a minute, please, John.
Okay.
There's just one small issue. We'll solve it in a moment.
You briefly had it, but it went off again.
Okay, Professor Toel, we will step to Professor Zito, then back to you. Okay.
There's something wrong. This is a really
Yeah,
very.
okay, you're on the, okay, you're sharing the screen now. Okay, go ahead. Continue.
Can you see your first
Now
slide,
my
please?
first slide is on. Is it okay?
Not yet, not yet.
Go on the Zoom and see.
No,
Share screen.
Okay.
You're off the share screen.
Yeah,
No, you're off the screen. There, you're back on now.
yeah. Okay, so
Click,
photos.
click on the slide now.
Just wait for the
You have
photos.
the screen, you have control of the screen.
Okay, John, we will start with Professor Zito, then back to Professor Toel again.
Okay,
Professor Zito, please start sharing your screen.
Yes. Hello, everyone. Thank you very much for
Hello.
the. How are you, Same? I'm sorry for the delayed, but it's an honor to be sharing this webinar with all of you. With thank you, Dr. Samet, and thank you, Dr. John Bennett, and all the rest of the lectures, Professor Marcos, Professor Liu, Dr. Turel, and all of the rest around here. I'm going to share my screen. Thank you very much. Okay. Okay. Can you see my screen now?
yes, perfect.
Okay. Talking about the most remarkable lessons for us, for my group, in a way, it's difficult to think of something else than anatomical concepts, than anatomy. For us, anatomy is the most important part of course, we have to neurosurgical practices made of different points of views from medical decisions, but the anatomical concepts we consider are crucial, are so important, and sometimes it has been, due to technological aspects, it has been in a way delayed. So for me, I want to talk about the anatomical practice. We've been doing some practice with our team, with our lab, doing some dissections, and we, in a way, englobed everything in a manner that we talk about understanding the skull base anatomy in a 360-degree fashion. What does that mean? That means understanding the 3D anatomy in the different aspects, from the cortical, from the endoscopic, in a 360-degree fashion. So we consider that that is something that is very important, mostly in educational concepts, in new generations. So it is very, very important. So what have we done in order to achieve this? We are doing some courses here in Mexico City, where we start with, we call it the first course, part 1, 360-degree. It's unlocking the middle fossa, the cavernous sinus, and the paracellar region. That's the first course in a way that we do. The second course that we are doing is the second part, which is the temporal bone and the posterior fossa approaches, in understanding, for example, foramen jugulare approaches, all the transtemporal corridors and far lateral, and all the different temporal approaches. And the third course that we do is the advanced endoscopy course, in order to understand all the sagittal and coronal planes that we can achieve through this endonasal corridor or combining it with some other corridors through the anterior part of the face. And so achieving all of these courses, we can, in a way, understand the 360-degree fashion of the anatomy. We do it like here, our fellows are working in the lab, and it's very important in order to this is the place where we have to learn, doing first in the lab, and then when we have experience and we have with a good mentor, we can go to the patient. And so understanding the anatomy becomes understanding from the anatomic point of view, even from the anatomical relationships from the sutures, in order to have the anatomical relations with the inner and the sulci and the brain anatomy, not only the skull base, and also, as we have been mentioning, also the skull base and understanding the relationships of the neurovascular relationships of all the structures. And so, for example, in a way, I always tell my team, my fellows and residents, that we always have to have in our mind some kind of GPS in order to GPS or neuronavigation, in order to have axial cuts of the anatomy, to have sagittal cuts of the anatomy, and understand the pathology, how it moves, how the relationship of the pathology with the anatomy. We don't have to understand the anatomy of the tumor only because of the location, but we have to understand the origin of the tumor. We have to understand how it displaces the normal anatomy in order to decide what is the best surgical corridor of that specific pathology. For example, if we go as an example for the pathology that we can achieve, that we can treat with after the first course, it's, for example, this complex skull base tumor. This is a young patient. She's 44 years old, female patient, and she's asymptomatic. And so, but she has this gigantic petroclival tumor. And so what do you do with this patient? She's completely asymptomatic, just eventually some headaches, no cranial nerve deficit, no motor deficit. And so we have to be responsible. We have to be and try to understand how the growth of the tumor is going to displace the normal pathology. For example, this tumor, we know that it's going to be originated from the petroclival region. And some might say that the retrosigmoid corridor, it's a corridor in order to achieve this, but we are going to have the normal nerves, the cranial nerves of the posterior fossa displaced laterally by this tumor. So in a way, we have to understand also the pathology and the surgical corridors. And so, for example, in this case, I see that this tumor is going to be located in this region. And so we might say that achieving this surgical, of course, this is an anatomic point of view, but from this surgical point of view, we can do a combined petrosal approach in order to achieve the anterior petrosal, and we can also use a partial posterior petrosal approach to achieve this kind of tumor in order to avoid, as we can see here, the seventh cranial nerve, which it's a possibility to injure in the tumor. As we can see, this coronal and sagittal views, it's a tumor with such a gigantic point of this is the incision that we do for this patient. We decided to do a combined petrosal approach, as we are doing it here in this cadaveric specimen. We do a supra and infra tentorial craniotomy. Very important to have exposed the Troutman triangle. We did a tailored posterior petrosal. It's not a complete posterior petrosal because, as you can see, we try to take the most advantage of the anterior petrosal approach. Here we are seeing, this is a crucial part of the middle meningeal artery in order to unlock in a way from posterior to anterior the posterior part of the cavernous sinus. We do a posterior peeling. As we can see here, we can see the V3, the arcuate eminence, and this is the posterior medial triangle of the middle fossa. And here we have the Kawase's triangle, and we are doing drilling. This patient had a pneumatized apex, and so it's very important to do an adequate post-operative reconstruction. Here we can see we could see the posterior petrosal approach. We can see Trotman's triangle. We have to tailor the posterior petrosal approach. This is the way that we do the opening of the posterior fossa. We start from the posterior fossa to get some CSF. Then we coagulate the superior petrosal sinus and we cut it, and then we can go and cut the tentorium, as we can see here. This is the tentorium, and at the border of the tentorial edge, we can see that we can identify the tumor, and it is very important to identify the fourth cranial nerve in order to cut that last cut of the tentorial edge. Then we continue cutting the dura, and we have two arms, one that goes to the anterior petrosal approach and one that goes to the Meckel's cave. In order for us, this is very important to unlock the trigeminal nerve, in order that we can have the trigeminal nerve freely, in order, as we can see here, this is the 7 and 8 complex. And so at the end, my approach is going to be completely all around the trigeminal nerve and not around the 7 and 8 complex. And so I can move the trigeminal nerve and continue removing the tumor. As we can see here, we have the fourth cranial nerve. And after we are removing tumor, we have here the sixth cranial nerve. We have the brainstem. And as you can see, we can work on different sites, on lateral and medial to the trigeminal nerve, and we can continue removing the tumor, and we can preserve the fourth cranial nerve, as we can see here. And this is a quite fast addition, because it takes many hours, but as you can understand, doing microanatomy and an adequate reconstruction with this free pedicle flap, it's very important in order to have a wide resection of the tumor. As we can see here, we have a gross total resection of the tumor. The patient had a sixth cranial nerve in the immediate post-op. This is the day after the surgery, and after 3 months, she completely recovered. And so in a way, it's understanding where to attack the tumor in order to cause the less cranial nerve deficit in every case. It's very important. Then, for example, in the next course that we're talking about, the posterior fossa, we can see the posterior. This is a complex foramen magnum tumor, meningioma, which has a severe brainstem compression. The patient came to the hospital and she came like in really bad shape, and she was intubated as in the emergency room in the ER. And for example, in these cases, what is very important? It's very important to understand the relationship of the hypoglossal canal and also understand the anatomy of the occipital condyle, in order to have and to do as much as is needed, but very important to do understand the far lateral approach and understand the relationship of the condyles and doing the drilling that it's needed for that specific case. What do we do as we do it in the lab and in the cadaver? We do a posterior, we do a far lateral hockey stick incision. Here we can see the occipital artery, the suboccipital triangle, which has in the middle the C1, and we can see the vertebral artery the relationship that has with the suboccipital triangle. So it's very important to apply these anatomical concepts to our case, to every case. And so this is after, this is the relationship of C1 and the dissection after we remove the occipital triangle. As I was saying before, it's very important to identify and to know what is the advantage of doing a transcondylar or a retrocondylar approach. And so in here we can have some extra exposure and to see and to understand the relationship that we're gonna do. So for example, in this case, we do it as the same as we do it in the lab. We go and do we did the same incision in this case. We can identify the vertebral artery. Here we are drilling part of the condyle, and very important in order to identify the condylar vein. And when we are done with the drilling of the condyle, then we can open the dura. And as we can see here, we have the arachnoid. As we can see here, it's very important to always preserve and dissect the arachnoid membrane. All the arachnoid planes are your best friends in a way, mostly in every type of surgery, but mostly in meningioma surgery. And here we can see the 11th cranial nerve. We can start the debulking of the tumor. It's very important to start debulking the tumor in order to avoid having any contact with the bulbomedullary junction. All the manipulation has to be all around the tumor. And so in this case, we are doing the debulking, we are removing the tumor in a piecemeal fashion. And we continue, very important to be gentle, using ultrasonic aspirator, having the appropriate. At this moment, I see that I can't see the tumor implant. I cannot see the origin of the tumor, and so I feel like I'm not comfortable because I can only move and work around the tumor. And so what do we do? What we do is that we identify the dural ring that is that has the vertebral artery communicating between B3 and B4. And what we do is that we mobilize the vertebral artery, as we can see here. And very important that, and then at this moment, we can mobilize it with a surgical loop. Very important not to have any branches to the spinal, to the brainstem. And as we can see here now, at this moment, with this mobilization that we did, we can attack the tumor from its implant. And so I know that here I am attacking the tumor directly to its origin. And so we can move medially or laterally the artery, and we can continue with the debulking of the tumor, taking care of all the branches. Here we can see the clivus, and very important to be really patient. And back there, I can start to see the hypoglossal nerve from the contralateral side. And we continue the dissection. And now I can see here the hypoglossal nerve. We can see 9th, 10th, and the 11th cranial nerve. And with this mobilization of the artery, now I can have a better removal in the implant, since this tumor has a ventral attaching zone in the clivus, in the foramen magnum. There we can see the 12th cranial nerve from the contralateral side. Very important to be very meticulous and refine the microsurgical technique. And so we can continue with the removal, and when it's completely free, very carefully, we can remove the complete removal of the tumor. and we can coagulate the implant, and we can see that the vertebral artery, all the in order to the mid-clivus. This is the post-operative, and to see the drilling of the condyle, and this is the post-op MRI. And as we compare the pre-op and the post-op, and the most important thing is that the patient in the immediate post-op, she's adequately improving her severe motor deficit that she had when she came, and very important that after 3 months she was completely with a great improvement, starting to walk, and she had a really severe preoperative motor deficit that she improved a lot after the surgery. And so, for example, in this that's for the posterior fossa, but also the anatomical concepts for the endonasal approaches. What do we do, for example, when we have this kind of tumors? These tumors, I was quite worried because of the relationship of this tumor with the basilar tip and the perforating vessels. I was really worried about this specific relationship. I was thinking of either doing a transcavernous approach in order to have a good view, or an endoscopic. So, for example, if we did a terional approach, this is the corridors that we would be seeing, and we'd be working around the triangles, but in a way it would be limited. So for us, also the height of the tumor, it was quite high. We would have to go through lamina terminalis, which it's an option, but I was not convinced about this lower part of the tumor. And so at the end, we decided to have a good view through an endoscopic approach. For example, this is in our dissections. The cadaveric dissections that we do in the lab. Oh, I'm sorry for this. Here it is. And so this is the preoperative. This is the preoperative CT scan, which was really calcified. And what we did is we did an approach, a transcavernous approach. As we can see here, we expose the cavernous sinus. We expose the medial wall of the cavernous sinus, and here we are opening, and we can see here the inferior epiphyseal artery. And what we do is that we coagulate the inferior epiphyseal artery, and we cut the artery, and then we can start dissecting the dural rings attached to the hypophysis, and then we continue and open the opening through a planum sphenoidale and transtuberculum approach, and then we continue with the dissection. We open the dural rings, and we have the dural rings, the ligaments attaching the ligaments attaching the hypophysis, and we can have the exposure that we can gain with a transposition, a medial transposition of the pituitary gland. Here we can see the dorsum of the posterior inclinal process. We have the dural rings. And so we continue the dissection, and now we can open the arachnoid. And as you can see, we can have all the relationship of the pituitary stalk. And here, this is the part I was worried about the junction with the basilar artery and the perforators. And we can continue, the removal. And we really consider that this maneuver was helpful in order to have the complete removal, the gross, the maximal safe resection of the tumor. And so that was a recent case. And so at the end, the conclusions of this analysis for us is always do a thorough analysis of each case. Consider all the anatomy, consider carefully each case, consider the possible pitfalls, consider, very important to consider your medical environment, how your team is developing, how your team is growing, in order to continue improving. Also do a lot of lab work. It's very crucial, it's very, very important. And always work with your team in order to continue improving and trying to bring the best that you can do for your patients. This is part of our team and the courses that we do here in Mexico City. Everyone is welcome. And in the future, we're having in October this course of the endoscopic approach. So thank you very much for the invitation. And thank you very much, everyone, for joining us.
Thanks a lot, Professor Zito, for this excellent presentation that emphasize the importance of learning neuroanatomy and cadaveric lab dissection. I see Professor Sayed has a question for you. Professor Sayed, please unmute yourself and ask your question.
Go ahead, Saeed.
Hi, thank you very much, Diego, for this great presentation. I want to know just the indication of this, the last case of supracellular calcified tumor. What was the indication?
This was a tumor which was a craniopharyngioma. It was a craniopharyngioma. Yes, a craniopharyngioma. And yes, as I mentioned, I was really worried of the relationship with all the perforating vessels of this craniopharyngioma in this young patient.
Okay, thank you very much. Thank you very much.
Thank you very much, Professor Said.
Thank you. Is there any question from panelists?
So I think you can put a.
Okay.
The mic is on.
Yeah, okay. Can I just make a comment? I think what you have shown very beautifully is not only the importance of anatomy, but what is the lesion doing to this normal anatomy and making it abnormal. So you need to see the abnormal anatomy in the light of the tumor, and what is this tumor doing to the basic neurovascular structures, and which are the structures that you need to take care of whilst you're operating. So the importance of neurovascular structure. Every tumor has got a key point. There are two key points. One is the epicenter of the tumor and how you're going to reach that area. And the second point is the important neurovascular structure. For example, in your foramen magnum, you nicely identified the vertebral artery and moved it out of your way so that you have avoided one major disaster. I think vascular structures are very important to know from your imagination where they would be, whether they are perforators or major vessels, and how you would be able to take care of these neurovascular structures. That's the key point. Otherwise, you'll end up with a good tumor removal, but a very bad outcome of the patient. So these are, I think there's no substitute or no replacement for knowing your anatomy. And this has to be studied very carefully on the imaging, and not just the gross imaging, but every slice will teach you something. Every small slice of the imaging will teach you sequentially where this abnormal anatomy is located by the lesion. So this was a very nice lesson to learn from you, Dr. Diego. Thank you very much.
Thank you very much for your kind words, Professor Keki. Appreciate it. Thank you.
So,
thanks a lot, Professor Diego, for this excellent presentation and discussion. See you soon.
Yeah,
Now,
thank you, Professor Sami. Thank you.
And now we will shift to next speaker, Professor Toel. Please start sharing your
Yes,
screen.
thank you. Sure. Okay, share screen. So this time I changed my computer. I hope you can see me.
There you
It's
go.
okay. It's
Yeah,
okay now.
all right. Thank you very much. So my first slide is always namaste. Namaste is to say that this has now become very fashionable, especially in the pandemic time, where you don't touch people. This is a very traditional, thousands of years old Indian discipline, where you greet people by folding your hands and by honoring each other. Okay. So I'm moving to the next one. Yeah. Thank you, Dr. Sameh, for this brilliant idea that you have put up, along with Professor James Liu. I thank James for asking me to be also here on this very wonderful program. Amongst the many teachers or mentors that I've had in life, the greatest teachers that have been my patients. Not so much the ones that did well or get cured, but particularly those who developed complications. Come on, it's not moving. An unfortunate part, so we have learned from complications is an unfortunate part of surgery, making consequences worse than the original disease. It may bring great suffering to the patient, to the family, and also tarnish the reputation of the surgeon and our specialty at large. You know, every medical field has complications, and complications in neurosurgery particularly can be quite devastating. And this is what led us to create a platform whereby neurosurgeons would share their difficulties, their problems and setbacks, helping us to learn from each other on how to avoid complications. And if they did occur, then how to manage them. This, I believe, is the concept of the series of webinars that you have been holding, lessons from the OR, for the education of neurosurgeons of all genders, and eventually benefit the very purpose of our being, namely to relieve the suffering of our patients. So the most remarkable lessons learned from OR, take this out from there. The crucial thing that often saves the day is one's awareness. And that is the current awareness of the current situation. Situational awareness is defined as a person's perception of the elements in the environment within a volume of space and time. That's perception. The second point is comprehension of their meaning. And thirdly is projection of their status in near future. In simple words, it essentially means is to have an understanding of what's going on and what is likely to happen next. That's number B, that's comprehension. And projection, that means what steps need to be taken. So what you're seeing, the small little slide on the right-hand side at the bottom, is you are gathering information by perception and also from communication and by observation. So from all sides, you gather information to have an understanding of what's going on, and then what is likely to happen, and then what steps you need to take. So this little scheme, again, emphasizes perception, comprehension, and projection, which eventually results in our decision on performance of action that needs to be taken. This situational awareness is a critical concept in any field that involves complex dynamic systems where safety is a priority, such as in aviation. It's similar to pilots, surgeons making complicated clinical decisions with available information while facing demands and distractions from the environment. So neurosurgery is particularly no different from aviation. Unfortunately, in surgery, great deal of emphasis is placed on executing technical skills. We just saw numerous beautiful presentations on these technical skills. However, the so-called soft skills, such as situational awareness, more so remain neglected. And there is no methodical training nor any structured evaluation of situational awareness that exists up to date. The consequence of turning a blind eye to SA could be catastrophic, and that would fail our patients who warrant highest level of safety, similar to fields such as nuclear power station or aviation, where SA training is an absolute norm. So as early as World War I days, where it was seen being used by Douglas Aircraft Company during research to reduce mental strain and fatigue. This concept became widespread, especially in the 1990s, by USAF crew returning from Korean War and the Vietnam War. Having been engaged in innumerable intense dogfights, good SA was identified as a decisive factor in air combat engagements, and that was later termed as the ACE factor. Since then, SA has been recognized as an extremely important concept with far-reaching applications where stakes are high, where time is limited, and permissible error is nil or negligible, such as air traffic control, nuclear power plant, and surgery. For a pilot, SA means having a mental picture of the existing interrelationship of location, flight conditions, configuration, and energy state of the aircraft, and maintaining those in adverse scenarios such as loss of control, wake vortex turbulence, strong headwinds, which is all aircraft terminologies I'm using, but I have actually studied this very extensively with my aviation friends. Similarly, for a surgeon, it means maintaining a clear and complete mental picture of patients' preoperative and intraoperative data, physiological and pathological parameters, existing state of men, that means self, patient, rest of medical, non-medical staff. Secondly, material, which is technology in the OR setting, and ability to maintain this equilibrium in an adverse event, such as catastrophic blood loss, severe brain swelling, and so on. I'll give you two examples of catastrophe in neurosurgery, which will illustrate this concept of situational awareness. Let me show you scenario one. A 74-year-old gentleman is brought to emergency in a comatose state with a large chronic subdural hematoma, a very, very standard routine thing that we see on a daily basis. History, examination, and relevant medical details are noted by the casualty medical officer and passed on to the resident on call. Promptly, the patient is taken up for an emergency surgery without really thinking too much. I mean, it's something that we see quite regularly. The anesthesiologist noticed momentary bradycardia and immediately informs the chief resident. At that instance, the junior surgeon realizes that the patient has been on aspirin for quite a while. Having found himself in catch-22 situation, sensing the so-called urgency, he decides to use a handheld press, which he had never used before. Why? The standalone mechanism which he wanted to use was unsterile. So here, why is it not working? Okay. So unfortunately, while this Hudson's brace is being used, the drill plunges. It plunges and injures the brain. So scenario two, I'll come back to this scenario one in a short while. A very senior surgeon of accomplished technical skills is operating on a large planum sphenoidal meningioma. It is late in the afternoon and it is in this third case of the day. In order to have a quick lunch, he asks his resident and the OR technician to put skull clamps and position the patient. After having a quick confirmation with the position visually, he proceeds with surgery. As he is nearing anterior communicating complex and plane of the tumor, the patient violently coughs, thereby causing slippage of the head. There is damage to ACOM complex, which result in unfavorable outcome. Now, just prior to this event, the anesthetist had been texting and coordinating a CME meet that was due that late evening. So there are two scenarios, two surgeons of varying experience having one common outcome: catastrophe. The question is, are these just unfortunate incidents or a work of destiny? Could these have been predicted and prevented? The errors have happened despite the level of experience, knowledge, and skill of the surgeon. However, if you notice carefully, the common theme that was missing in both these instances was situational awareness. Having gone through both the clinical scenarios, let's have a basic understanding of this SA model. Then we would analyze both the scenarios through the eyes of this model and try to reason out where things went wrong. This is a situational model of Hensley with these three elements: the perception element, perception of elements in the environment, noticing what is going on, which is level 1. Then we have level 2, where you have comprehension of the current situation, processing the information to make sense of what is happening. And then we have level 3, which is perception or projection, of future status, deciding what tasks, decisions, and actions need to be taken. On the left-hand side, the perception means facts, history, physical investigation, and so on. Perception, comprehension, interpretation, stores, the retention, what's going on, and projection of future status, what is most likely to happen, and what exactly should I do in such a thing. So using this Hensley situation model, we propose 3 levels of SA. Level 1 SA involves perception of information and cues from the environment. There's no interpretation of data occurring at this stage. Translating medicine, what SA means, what are the current facts relevant to the case? In medicine, it is primarily the process of getting information via history, via physical examination, and diagnostic tests prior to any intervention. We have level 1 SA involves perception of information and cues from the environment. And level 2 is comprehension of the situation and the way an individual combines, interprets, stores, and retains this information. It leads to development of an accurate picture of what's going on and the ability to make judgments about the patient. So level 2, now we have level 3, ability to forecast future examination, future events. What is most likely to happen? What is most likely to happen if, now McGuinness and Foy proposed a 4th level to this model, which actually translates to what exactly should I do, or if all these things have happened. So let's go back and analyze scenario 1 in this framework. Not being aware of the fact that the elderly patient was on aspirin, not being aware of how to handle the Hudson race, led us to basic error level 1 of perception, not knowing the facts correctly. Additionally, the distraction provided by the possible false alarm, which was raised by the junior anesthetist, compounded this issue, and that led to failure in comprehension of the entire situation, which is level 2. Failure in comprehension. And then we have subsequently having chosen the wrong instrument, which is level 3 error, projection. So we have the same thing: perception, comprehension, projection. P, C, P, every time. Projection means decision making. Additionally, in a so-called and perceived urgent scenario, looking at the broader picture, the resident could have used unsterilized drill if the sterile drill was not available. Well, he was not familiar with the Hudson's race. Primary objective of safely releasing the hematoma could have been achieved. Of course, infection could have occurred, but that could have been dealt later. So information overload can lead to paralysis of mind, as you saw in this case. A good history taking, revealing his inexperience in handling Hudson's race, noticing but not reacting abruptly when alarmed, calling for help, simulated drill training on cadavers models, all these could have either deferred or minimized the impact of damage. Let's look at analysis of situation 2 in the model. In this case, a very experienced surgeon landed up with a terrible complication, not due to his lack of technical skill or event, rather due to system and methodology flaw. The resident, without being aware of the importance of skin bunching on site around a pin, he remained blind, leading to level 1 error, as explained before. The chief surgeon, also probably distracted by the idea to finish the case soon, he failed to comprehend impending problem, hence losing level 2 of awareness. The anesthetist, In addition to being blind to the fact that pins were not put properly, she was there, she was watching it. She was also distracted by her own preparation of the evening's webinar. So failing to notice early warning signs of patient being light was an act of omission or incorrect judgment or prediction. This is loss of level 3A. The OR technician now, though he was completely aware of the anomaly, he did not pass this information on to the surgeon due to strict hierarchical structure. He was afraid of being rebuked by the senior surgeon. He had the facts. He knew this could be a problem. However, he failed to realize the most likely scenario that could happen, possibly in a worst way. This is also level 3. Additionally, he had this choice to disclose or not to disclose. He made the wrong choice, demonstrating level 4 of McGuinness and Foy. That is not knowing the best option to take. All these were cognitive factors of individuals. However, environmental and methodological factors, such as keeping a complex case in the end of an unusually busy day, a mentally distracted surgeon due to overload of cases, a preoccupied anesthetist, and a technician who, despite noticing an anomaly, chose to remaining quiet, probably also played their role. So as you see, the bad outcome was directly related to situational blindness, more so with the team rather than a surgeon alone. Are we not low on the battery? Okay. So situational awareness incorporates the cognitive approach and the systems approach that gives an excellent opportunity to address surgical errors and improve patient safety. In other words, SA could be lost due to any adverse event that could disturb the equilibrium between 3 M's, the men, the materials, and the method. Here, method signifies both static and dynamic information subsets shared between the men and the materials. So here we have ourselves prepared an additional kind of a model where the surgeon stands in the middle. He stands in the center of the information input from patient, from other staff, and the hardware being used. This data can be static, example, patient's pre-morbidity, limitations of equipment, or dynamic, like blood pressure, communication with scrub-nurse, with the assistants, etc. This all leads to data overload and inattention blindness. As seen in this case, it was a catastrophic failure of the entire team, as you see over here in this human pyramid. And it shows the importance of being aware by just not one single person, but all concerned individuals in a complex, dynamic environment, such as the neurosurgical operation theater. Taking examples from the aviation sector, it is possible that the soft skill can be taught and trained just as a pure technical skill. Even in medicine, it's been shown that in fields such as emergency medicine, anesthesiology, intensive care unit, the proper addressal to SA and its utilization indeed raises the safety standards. So take information from this. I would suggest a few ways SA can be improved. Let's see. The first part is impart SA training to all. Surgery is a complex teamwork, and it is vital that members of the entire team is aware at all levels what role to play in routine, crisis, and never been there situation. Everybody should know what to do in both routine and crisis events. Surgical crisis code and drills are the way to move forward in this regard. We propose an algorithmic loop that can be utilized during the occurrence of an adverse event during surgery, which could help declutter the information and reveal a broader picture so that appropriate action can be taken in a short time to negate complications. To re-emphasize, preparation starts preoperatively. We have again prepared an algorithm. Sarkar and myself have together prepared this surgical safety loop. Starts with be prepared. You have an adverse event. You communicate. You evaluate. Having evaluate, you act, react, but certainly don't react. And then you anticipate what to do in this kind of a cascading events. And then again, come back to being prepared. So this is the kind of a loop, surgical safety loop, that you need to be aware. This safety loop should run through a surgeon's mind before and during an operation. This will help in maintaining a situational awareness, a kind of a balance, and declutter sensory overload. Situational based training is point 2. Simulation based training can be provided to the residents to hone the surgical skills before even trying on patients. Even accomplished surgeons can use this technology. The aviation pilots, all of them are experts, and they use this technology. It raises the situational awareness by replicating real-time scenario and possibly worst-case scenarios to predict the disaster preparedness. To avoid distractions, significant distraction can occur due to vast array of alarms, such as and data sets. Simulation training should include how to avoid distractions, such as alarms, comments, telephone conversations, repeated door opening and door closing in the operating room. Methods to improve situational awareness. Point 4, teamwork and communication. Measures should be taken to build team spirit where every individual develops a sense of belonging and he or she subconsciously becomes a part of the process. Things like time in and time out, universal surgical checklists, confidence building measures and mock drills can be useful. Creating a strong hierarchical events creates barriers to effective communication within a team, as witnessed in our clinical scenario. Well, remember, instead of blame game, any wrongdoing should be dealt with in a humane, fact-finding method rather than witch hunting. No blame game. The next method to improve essay is critical analysis of the so-called near-miss events as well. In addition to mortality and morbidity meetings, critical analysis of the so-called near-miss events as well. These near-miss events are those in which adverse events did occur. However, they were managed and the worst outcome was averted without resulting in undue morbidity or mortality. So today, methods to improve, I would say, next point, I would choose to stay calm. Stay calm, be calm. It should be emphasized that particularly to junior colleagues to remain calm in crisis and to call out and not to shout out or pass out. Calling for help from another colleague can be of immense value. So how do you do that? Knowledge update. You must have continuously, we are having a lot of inputs. It is impossible for a surgeon, single surgeon, to experience all adverse events in this lifetime. Therefore, to enhance this awareness, sharing experience on platforms like ICCN. ICCN is International Conference on Complications in Neurosurgery. We have local body meetings, journals, relevant social media handle. All these can definitely improve one's awareness and raise patient safety standards, to which we are all committed to. We have these meetings of ICCN international conferences, which is a unique educational initiative that we have had. So in addition to pure surgical skill, situational awareness is an extremely important behavioral, non-technical soft skill that must be learned, acquired, trained, and shared to minimize surgical errors and crisis mitigation. Structured teaching framework directed to improve SA is a need of the hour. Awareness of the safety loop, as proposed by us, in addition to the universal surgical checklist, will further help surgeons to counter events during surgical procedures and raise standards for patient skills. We've had these international meetings already in 2017. That was the first time we had this complications meeting, where we emphasized that complications makes treatment worse than disease, and there is suffering of the patient, family, surgeon, and our own specialty. And where we emphasize again, prevention is better than cure, which we have seen again in these past few presentations. So we had a very successful first meeting, after which we had a second meeting that was, why is it not moving? We had a second meeting in 2019, again, very successfully handled. And then we had the third ICCN, which was unfortunately, not fortunately, I would say, which was only virtual. We could not have a physical meeting. But you would know that this meeting was attended by a staggering 13,000 neurosurgeons across the world over 3 long days, about 12 hours each day. And so now we are moving forwards to the fourth ICCN, which will be held next year in 2023, March 10th, 11th, and 12th, at the same place that we had our second physical meeting. And I would like to say that please emphasize on this date, 10th, 11th, and 12th March. We would like you to be there physically. I learned so much by these past few presentations made this evening. And I think all of them have emphasized not only what to do, but what not to do, or what I would have done differently if I had landed these problems. And so please come and join in these. Can you see the highlights? Anticipation, prevention, and management of complications, ethical considerations, philosophical aspects, moral obligations and probity, and legal implications, frank discussions on pitfalls of management. As I said, how I would not do it. And this was so nicely showed by James also. How I wish I could have done this differently. And this will be an open forum of our failures and what we have learned through them. We all know failure is a defeat only if you don't learn from it. So let's be very clear about this. This little algorithm shows you all the kinds of problems that occur during complications. I thank you very much. Dhanyavad in our language means thank you so much for sharing and for allowing me to speak on this wonderful topic on complications.
Thanks a lot, dear Professor Tuel, for this excellent presentation. I'd like to congratulate you about your series of complications. We have learned a lot from this series, and we wish you more success in next versions. If there is any question from panelists, please. Any questions from panelists? Okay, thank you, Professor Tuel. And now we will shift to next speaker, Professor Marcos. Professor Marcos is one of my best dear friends and has a neurosurgical series that we all know about it. And he has invited a lot of international faculties to this eminent series. I'd like to congratulate him a lot for his successfulness and wish him more in next versions. Please, Professor Marcos, touch your screen. Thank you.
Thanks, Sameh, and thank you, Jim. You can hear me and see my slide, I assume?
Yes, it's okay.
Great. Well, happy Saturday to everybody, and or Sunday to some of you maybe. So I thought I will talk about some intraoperative disasters and forgive and remember. It so happens this month I published my thoughts about how to deal with neurosurgical complications in the journal Neurosurgery, kind of how we deal with them on a personal, visceral level, which is a nice follow-up to what Keke Turel was talking about. So I encourage you to read it and see if you share the same thoughts I have. I've been enjoying sharing kind of cases on a daily basis on Twitter with the handle, with whatever you call the hashtag Marcos Challenge. So every day we put a case. They're not, of course, complications, but some of them will be. So I'd love to have you share your thoughts with those things. Okay, I am going to see if I can run through 5 cases, but I'll make sure I stay on my 25 minutes. 53-year-old man, loss of smell for many years, recent headaches and mild cognitive changes. You can see the CT of the brain with bifrontal edema and a skull base lesion. You can see it here. It's partly intranasal, partly intracranial. It has all the features of anesthesio-neuroblastoma. And I thought it was lateral or eccentric enough to the sides that pure endonasal would not be a good idea because it'll be difficult to reconstruct and deal with the top part of the lesion. So we decided to do, by the way, note the relationship on the CT scan to the optic canals that will come in shortly. So we decided to do a combined bifrontal craniotomy and endonasal endoscopic approach, of course, with our ENT colleagues. The endonasal portion was done first. I was not involved in it first, and then I came in the same day, of course, on the same anesthetic to turn the bifrontal craniotomy. And I don't have the video of the intracranial portion, but when I reached down to the tumor, I noticed that the optic nerve on the right side was traumatized already, missing its medial portion. So then I, of course, called my ENT colleague and we pulled the video of the endoscopic portion that was just done a couple of hours before. And I don't want you to forget what you're going to see here. And let's see if you can recognize in a second what happened. This is the ENT team drilling. Do you see it? Right there. It's heart-wrenching. I'm going to replay it because it's fast. Notice right there, he entered the right optic canal, and you see this is optic nerve material swirling around the drill. He did not recognize really what the OCR was. You see it? It wasn't the entire nerve, and this was unrecognized at the time until I turned the craniotomy. The patient, anyway, I proceeded to do the case and to show you on a post-op where the red arrow, this is where the endonasal injury to the medial optic nerve was. You can see it where all the arrows are. So what is this mistake? This mistake is I guess, level one in Dr. Turel's thing is not recognizing the facts. The facts is where is the OCR, and you obviously cannot drill into the optic canal like that. So, and there it is again. You see the emptiness, lateral optic, I mean medial to the optic nerve in this case, and compared to the normal optic nerve on the other side. The patient, interestingly, did not have complete blindness in that eye. It was just a partial field cut, surprisingly. So again, to the young people in the audience who do endonasal, obviously, anatomy, anatomy, anatomy. Case number 2. This is a case of my partner. It's several years old. And the reason I show it is, again, it gives a good lesson. 30-year-old man who had a craniopharyngioma resected via a left craniotomy many years ago and radiation therapy, and the craniopharyngioma recurred. And here is the resident and the ENT fellow doing the opening endonasally. This is, and there we go. This is not as dramatic as what Dr. Liu showed earlier. So here is the things not to do, what they proceeded to do. Please don't take the suction bovie and do this like they're doing here. It will make the hole worse. This is, of course, scarred from previous surgery. So look, the bleeding is worse because you're trying to coagulate a hole that shouldn't be coagulated. Of course, it's easy to pack, so they're packing it, and they managed to pack it, but couldn't stop the bleeding completely. So I got called in at this time to try to see what to do. So we said, well, we need to turn a craniotomy. So I'm going to show you next, and this is nasal septal flap. And we turn the craniotomy, left side, left craniotomy, optic nerve on the left side. We think it's an A1 injury, and here it is. No, at least with the craniotomy, you have control of the situation. You can clip a temporary clip on A1, you can clip the other A1, which is what we're doing. And what this was, it was an injury of A1, A2 junction on the right side, because you can see the A1 was stuck to the dura. And the lesson here, before we get to the lesson, so we just strap it, but luckily it was possible to put a permanent clip, well, across A1, including the hole. We first tried to suture it, but bovie injuries to arteries are almost never suturable. Or if you suture them, you'll end up with a pseudoaneurysm. So here we decided, my partner and I, to just put a permanent clip across A1, the right A1, and of course that took care of the problem. So, and we do ICG. And here is, but there is a Hübner infarct on the right side, because that Hübner was injured during part of those coagulation, clipping, so forth. The lesson is to have recognized that the ACAs, by the way, I know we're supposed to show disasters. The patient did well, but the point is, he needed an endonasal and a craniotomy, but you can see the A1 is stuck on the dura. This should have been recognized on the way in, that if you're going to cut the dura, you'd better do it very carefully and recognize what is hidden behind the dura. So pre-op imaging studies, study them very well. Here is the ACA stuck to the dura, anterior to the tumor, because of the previous craniotomy. Clear communication. I mean, you know, should the resident be opening the dura at this stage? Probably not. And definitely don't use a bovie on arterial injuries. It makes no sense at all, makes it worse. Case number 3. This is a case of mine. I will never forget this young woman. You can see how old the case is. It's 2004. This is a 26-year-old woman with this acoustic neuroma. As I am doing a retrosigmoid approach, and I don't have a video to show you, but I think you will appreciate the complication. This is her audiogram. This is how I do my retrosigmoid. Everything's going well, but at the bottom right, what you cannot appreciate is I injured the pontomesencephalic vein on the brain stem, and I put Surgicel on it, an occlusive Surgicel on the vein to carry on the surgery. And within a minute, the entire cerebellum and the brain stem started swelling and bleeding. And I was trying to quickly take the acoustic neuroma out, very hemorrhagic, venous, almost instantaneous venous hemorrhagic infarction. In spite of removing the Surgicel, the vein was already injured. So it's one of those, I wish I had an angiogram pre-op, of course. It clearly is one of those venous anomalies where that vein was critical. And you can see the immediate post-first surgery, CT scan, swelling and more posterior fossa edema. I had aborted the surgery. I come back within an hour to do a second surgery, and this time it was so swollen. I did a transsigmoid, translabyrinthine approach, simply to manage the swelling and to get more space. It was really quite horrendous. I haven't had another case like this before or since, of such a magnitude of bleeding and hemorrhage and edema. And you can see she remained devastated. Look at the brainstem venous infarction. And she survived. She's significantly disabled. She actually cognitively is perfect, but severe dysarthria, severe ambulatory difficulties, just from losing a vein, a pontomesencephalic vein on the brain stem, which, to be honest, I don't know. I guess I should have been more careful and tried to save the vein, but it was bleeding as I was peeling the capsule of the tumor. And I did what I think most of us would do, is just put Surgicel on it. So this is almost 20 years ago. I actually saw her last year with those deficits that I described. I will never, honestly, never forget this case. Case number 4, 37-year-old female with recent severe headaches. She had a wedding, her own wedding, coming up in 2 months. She comes to me with this parasagittal meningioma, and she asks me, do you think I'll be recovered in time for my wedding? I said, of course, this is frontal, real simple, and no problem. So here is the MRI, nasty meningioma, lots of blood vessels. Look at the angiogram, arterial PL supply, quite a bit, including possibly the calloso-marginal branch. So my endovascular colleague, of course, thought it wasn't easy to embolize because of that ACA supply. The ECA supply is easy, but it was mostly ICA supply. This is an ECA supply, but that part is easy. I can take out on the way in, and I did. So we did not embolize the ICA pre-op. And so I proceed with the surgery. And the minute I touched this tumor, it was, again, horrendous bleeding. So here is, I'm sorry, let me go back. So I tried, every centimeter of tumor would take me half an hour to stop the bleeding. So I stopped, and I called my endovascular colleague right here, who was then with me, Ali Sultan. And I said, let's do intra-op direct tumor embolization. Puncture the tumor, please, for me, and inject it with onyx so I can continue. So, and the complication is related to this part, but I'll show you what it is. It is a single plane, a C-arm, not a biplane. I was not in a hybrid room at the time. And he does a very good job. I'll show you what he's doing. He's puncturing the tumor. You can see the needle right there. It's in the tumor, and he's putting onyx. And it actually goes very well. So now, after he's finished, I come in and I touch the tumor night and day. I can cut in it. It wasn't bleeding anymore. And I proceed to remove the tumor. No problem. Probably took me half an hour from this point to actually remove the tumor after it was horrific bleeding before. Here is the onyx cast around the tumor after I'm finished. You can see the big vessels in it. However, let's see if you can see what's wrong. You see the onyx cast, because he was using a single plane, went into the superior sagittal sinus, because he thought this was tumor vessel, and this is an onyx cast in the superior sagittal sinus, the middle third of the sinus. And of course, you can imagine what happened. Look what happened. Herniation, massive venous infarction. Look at this. Look at this. She had to go back to the OR with emergency decompressive craniectomy. We put her on barbiturate coma for about 5 days. Returned to the OR with emergency right frontal lobectomy. because you can see this is now 4 months. I mean, at the time it was 4 months post-op. Now, eventually she did make an excellent recovery, like 95%. She got married 6 months later instead of the month after my surgery. But of course, this is a devastating complication and outcome due to lack of recognition of, where the superior sagittal sinus and the danger of intra-op embolization. Now, had we not sent onyx into the superior sagittal sinus, this would have been a fantastic technique. And I've used it, by the way, 3 or 4 times. The other times in different settings, I've done it in the CP angle, some very hemorrhagic tumors where I call my endovascular colleague if there is no transarterial access to embolize intra-op. So if done, of course, ever since we either we do it in the hybrid room or we don't do it, it's dangerous to do with a single arm, C-arm. So please remember this complication if you ever consider intra-op tumor embolization. Case number 5, she is in the hospital currently. This is a very fresh complication. It's a tough case. I realize it's a tough case, but still it's a complication. This is an aneurysm that was clipped 20 years ago somewhere else. She came to my younger partner here recently. We don't know if it's a residual or recurrent MCA aneurysm. I'm going to freeze it just to show you the complexity. Do you see that there are 3 vessels, at least 3 vessels coming out of this aneurysm? There is an old clip. There is, let me see if I can, here we go. I think you see my mouse. This is a branch. We could not tell if this smaller aneurysm is part of the big one, but I can tell you from surgery, yes, it is part of the big one, and it is not a second aneurysm. This artery that I'm coursing around is extremely stuck. So this is the 4th artery we have to worry about. So we have to worry about 1, 2, 3, 4 arteries. 3 of them come out of the aneurysm, a large aneurysm. The 4th one does not. Of course, my partner is a duly trained endovascular, and he told me he has no endovascular solution to this. So then, of course, we need some form of a bypass. Now, she only has, this is wrong tracing. She only has 1 branch of the STA. She doesn't have 2 branches. Only the anterior one is alive. So we had the radial artery available. I dissected the anterior branch. What was very difficult is just reopening of the craniotomy. The dura was stuck. You can imagine 20 years ago, we would start opening the dura one place, it would bleed venously. Eventually, we made it to the aneurysm. I'm going to skip parts of the video, but I preserve veins as much as I can. So you can see the sylvian vein. I really went out, we went out of our way to stay around it, to try to keep it intact, even though it really was in the way. And I'll show you different views of the aneurysm. Here are some of the outflow of the aneurysm. So we open the neck, we expose the external carotid. The vein is still, now and again, it would bleed. Here is the old clip stuck to the vein. We're trying to really understand the anatomy. So I'm trying to decide, what do I bypass? I have 4 vessels to worry about. I have 1 radial artery, and I have a small STA anterior branch. I get a little bit of bleeding right here, which turn out to be not the aneurysm, luckily, because if we get the aneurysm bleeding at this stage before any bypass, we're going to end up with a massive infarction. This was just a small branch of one of the stuck arteries. I'm going to skip fast on this. Here is the radial artery. So I decide to bypass to the temporal branch right here, radial artery to temporal M2. I am going to go fast on this. No problem with this anastomosis. I tunnel it to the neck, and I go to the external carotid. This is, again, everything's going well here, and I don't have my final plan. I still don't know how I'm gonna bypass the other 3 branches. I am thinking of trapping the aneurysm, saving the other branches. I'll show you in a second what that means. That's done, no problem, bypass working well. Now, this vein is in my way. So I decide I need to take this vein, because I cannot understand the anatomy or create the space to do a deeper second bypass to one of the other branches. We are going to take the vein very shortly. I apologize for this. I didn't have time to really super edit it because this is just last week. Here we go. We take the vein. I figured, how harmful can this be? I don't have a choice. I don't know where to go next with the case. Now I have more room. I can get more distal exposure of those vessels. So now it's very clear to me what to do. I need to do a side-to-side bypass between this one and this one. And then I would trap the aneurysm, and then blood would flow this way, this way, this way, this way into the other 2 branches. That's what I did. I'm going to go a little faster on this. Side-to-side bypass, running suture at the back. Again, no problems with those arterial side. ICG is fine. Now, at last, I can do the trapping. Oh, by the way, I coagulate the aneurysm. Now I can trap it. I have a bypass that feeds all 3 vessels. This clip is on the M1. This clip is distal. I need to make sure I don't stenose this flow, because this is what's saving the other 3 vessels. I put a second clip to get this dog ear out, and I am very happy. I've done a perfect arterial reconstruction. I said, wow, we made it after hours of work. ICG fine. Here is her post-op CT. Perfect. CTA, everything is patent. Look at that. All the bypass is feeding everything. The aneurysm is gone. The next day, of course, you can't celebrate too early. The next day, she has an acute subdural hematoma. Of course, she's on aspirin because of the radial artery. Not only a subdural hematoma, but a venous hemorrhagic infarction, probably from losing the Sylvian vein and those veins on the surface of the brain because of the difficulty we had getting in and to do this kind of complex arterial reconstruction. She's still in the hospital. She is getting better. I have no doubt she will do very well eventually, but of course, this is again a dramatic complication. I had another case, but it's 26 minutes into my talk. I'm gonna stop.
Okay, we can take it, Professor Mokus, if you want.
I'm sorry?
We can take it.
You want me to do it? Okay, I'll do it quick. Okay. This is a vertebral artery pseudoaneurysm complication after an extreme lateral transcondylar odontoid approach. This is, I'll go quick. This is a 22-year-old female, recurrent chordoma. You can see it, craniovertebral chordoma. She had been radiated and operated elsewhere, and she comes with a recurrence, a rapid recurrence to us. Here is, you see the recurrence. So again, it came to my younger partner and we operated together. We did stage 1 endonasal and stage 2 ELTO, extreme lateral transcondylar. I'm not going to show you the endonasal portion, but this is left ELTO. This is me dissecting the vertebral artery, translocating it out of the foramen transversarium. I've already taken C1, and this is a good technique to do when you want to get to the odontoid, anterior to the cord, coming from behind. Of course, you have to translocate the vertebral artery. She's been radiated, so the planes were not very nice. It wasn't as easy as the virgin translocations I've done before of the vertebral artery, but it went fine. I did not have any intra-op bleeding. And you can see gradually I managed to move the vertebral artery. By the way, to orient you, this is where foramen transversarium was before I drilled it. Now the vertebral artery is free to be translocated medially, allowing me to drill the lateral mass of C1 right there. Of course, it's eaten away by chordoma. And then we're drilling and drilling the condyle, we're drilling lateral mass of C1, occiput C1 and C1, C2 joint. All that is invaded with chordoma. Drill the odontoid. I'm skipping because that's really not relevant to the complication. But I like this drill. It's very nice, curved, low profile. This is working around hypoglossal nerve. So I'm very satisfied with the degree of tumor we remove. And we do a posterior occipito-cervical fusion when we finish. Here is a vertebral artery, still looking very nice at the end of the case. Here is a post-op MRI. It's a really very good resection. Then here it is on axial, considering how invaded it is with tumor. Here is a posterior fusion. She goes home, and after 3 weeks, she has acute blood from her mouth, 25 cc. She goes to a local ER. Nothing is done. 2 days later, she loses 400 cc's of blood from her mouth, not the incision, from her mouth. She comes back to us, and she has a big pseudoaneurysm of that vertebral artery that, of course, because she's had the endonasal and the posterior approach, it communicates with the oropharynx. So this bleeding was going forward, and luckily she did not die, but we coiled it. Bad complication from handling the vertebral artery. Perhaps I should have been more delicate with handling the artery. It's certainly part of the, maybe radiation therapy didn't make it easy, but please be aware that when you handle arteries in a forceful way, of course, this can happen even if you do not get intra-arterial bleeding at the time. So, so those are some of the lessons I think I can make, draw from these various cases. Thank you very much.
Thanks a lot, Professor Marcus, for these interesting cases and excellent presentation. Is there any question from panelists?
Yeah, I can. Do we have time? I can ask a couple of comments. Okay. Jacques, you're brilliant as usual. And thank you for being so honest and showing your real complications. It's a very great learning for everyone. Now, let's come to a second case of not coagulating the hole from the carotid. I fully agree that every time you do a coagulation of a hole in the carotid, it only becomes wider. The exception here is that if you have a very, very tiny pinhole, then perhaps with a very low current and a broad tip forceps, you may be able to stop the bleeding under vision.
Oh
I
yeah,
don't know what-
I completely agree with you. With bipolar, what I
Yes.
said is don't use the Bovi. They use the
Oh,
Bovi.
oh, you can't.
No,
question.
of course. I have
No
a
question.
lovely non-stick bipolar that I use.
Yes.
Oh yeah, small holes. It works very well.
Yeah, I'm sorry. Okay, fine. Your second case of venous infarct, catastrophic venous infarct. Actually, I could have brought a couple of these cases myself over here, but it is true that venous infarcts can, and especially in the posterior fossa, small little hole, sometimes in a non-dominant transverse sinus, has even resulted in catastrophic brainstem edema. And I've got a couple of these cases I could have shown today, but I wanted to stress on situational awareness today, maybe on another occasion. But talking about the veins, there's no doubt that damaging veins is more unforgiving than damaging arteries. And well, we don't have a choice, but what I mean is, but the good part of it is that many of these venous infarcts do recover significantly. But if you are having, and they give you a good outcome, as you've seen with your meningioma in the supratentorial area. But still, sometimes, especially in the posterior fossa, taking away a vein, as a pontomesencephalic vein, which was unexpected, can result in a brainstem infarct, and it is very difficult to predict. I don't know how you would have, even if you had to do the same case the second time, what would you have done?
Exactly. It's so frustrating. It's what you don't know. I mean, I've of course done larger acoustics than this over the years, and this stuff hasn't happened. In her case, I think, you know, I remember a paper, I don't know if you were on it, somebody reviewed Majid Sami's series of petroclival, Tatajiba, I think, when he was with it, or some. The incidence of venous infarction in Majid's petroclival meningiomas was 29% venous infarction if they took the vein. Of course, we take the petrosal vein, or some people take the petrosal vein all the time with MVDs, they don't get infarction, but it's because it's the last working vein with a meningioma that's compressing all the other veins. So in my case, I think that acoustic, she must have compressed the other veins, and that's the only remaining posterior fossa vein. Yeah, but how to predict it? I don't know. Are we going to do angiograms on every tumor we do? No, but bad luck. I put it in the category of bad luck, and maybe bad technique as well. I mean, maybe I should have been more careful separating the vein, but sometimes you end up removing them anyway.
Yeah, thank you. Jack, you should come to the fourth ICCN and show some of these cases.
In March, yes.
In March, yes.
We'll be there.
You have betrayed me the first 3 times.
COVID, blame it on COVID.
Okay, thank you very much.
Thank you, Professor Marcus. Thank you, Professor Tuil. Is there any question from panelists? Okay, thank you. And now we will shift to next speaker, Professor Hisham Basuni. Please start sharing your screen. Thank you, Professor Mox.
Yeah, good day, everybody. I'm sharing my screen. Thank you very much for your invitation, Dr. Sami. And I'm showing only one case, but it is a rather recent case, so it still hurts actually. And just take some time to get the full screen. Can you see it? Can you see the full screen? No.
We don't see it, Hisham. We don't see it.
Okay. So wait a minute. Oh, I'm sorry. I have to. I wrong. Yeah. Now it should work.
It's okay now.
I'm getting back the full screen.
Okay.
So this is a
It's
rather
not full
recent-
screen. It's not full screen.
Yeah, it's coming. Hello, John.
Hello. It should be at the bottom. One of the
Yeah,
options.
I know, but it takes some time on this computer.
Oh, okay.
Got a new computer, but it's a bit slower than the last one.
Oh, okay.
Technical advances. There, it should. Can you see it?
Yeah, perfect.
Okay. So this was a case of giant basilar artery aneurysm, and she was admitted in February 22, and she's a 61-year-old lady from Argentina, and she presented with epileptic fits and decreased consciousness. And when she came into the hospital, she was already bedridden. She was in a bad condition, and she had a right-sided hemiparesis, oculomotor palsy, and psychomotor retardation. She had a previous history of treatment of the basilar artery aneurysm. It was in Florida, in the United States. She had in February 2018 coil embolization. At this time, according to the report, the aneurysm was less than 1 centimeter. Unfortunately, I had the original images, but they were deleted from our temporary hospital archive, so I could not get them again in time. But according to the report and also from the images, the aneurysm was completely obliterated at that time. Then in October 2018, she had another angiography, and this time the aneurysm neck of the basilar artery aneurysm was already 4.6 millimeters. But she had a pipeline, so nothing was done to the basilar artery aneurysm. But she had 2 other smaller internal carotid artery aneurysm, and there was a pipeline embolization also performed in the institution in Florida. So another control also in the United States was performed in December 2020. And now the basilar artery was measuring around 40 millimeters, and she had another coil embolization. So 7 coils were put in, and they showed, according to the report, complete obliteration of the aneurysm again. So when the patient came, actually she came with a bleeding. As you can see, this was the initial CT scan on the day of admission to our hospital. You can see here the blood intraventricular. You can see also a brain shift to the right side. You see the coils here, and you can see also a space occupying lesion, which was probably related to the aneurysm. So this was a preoperative MRI showing now, of course, from the original dimension of less than 1 centimeter to this dimension. So it was actually a giant aneurysm, which also was compressing and very much compressing the midbrain. And this probably explains the hemiparesis of the patient and also the oculomotor palsy. So this you can see there was also edema in the midbrain and also edema in the temporal lobe, surely from the compression by this giant aneurysm sac. And this explained the condition of the patient. She was bedridden and, as I said, in a very bad general condition. And this is the coronal image showing the aneurysm sac and also the perfused part of the aneurysm here. And this is probably the posterior cerebral artery, and this is the superior cerebellar artery. So the aneurysm, as originally also described and seen on the images, was lying between the posterior cerebral artery and the superior cerebellar artery, coming out from the more from the side of the basilar artery. So this is the angiography we performed. This is the lateral view. You can see here the aneurysm, the perfused part of the aneurysm, and the shifted and upward dislocated posterior cerebral artery and the superior cerebellar artery, and you can see it more on the oblique. Here is the perfused part of the aneurysm and the dislocated adjacent arteries. So I discussed the case with our neurovascular neuroradiologist or interventional neuroradiologist, and I thought when I saw this image here, this angiography I saw, it can be made, can be clipped. The interventional neuroradiologist said it is a difficult case for him, and so we decided for clipping. So when you see the MRI again, it is I think almost impossible to come from the side of the aneurysm because you have the sac, you have this space occupying lesion, and you will surely injure the temporal lobe, and also you will go actually blindly, even if you are using neuronavigation, but you will take off a lot of material, and then you will get into the aneurysm, and it's very difficult to handle, I think, from the ipsilateral side of the aneurysm. So I decided to go from the other side, and here you see the 3D angiography, this large coiling package and the dislocated arteries, and this is the perfused part of the aneurysm. By the way, she had also a smaller one on the P1 segment, but this was actually a side diagnosis. So I decided to perform a right-sided enlarged craniotomy, and this is the anterior extradural anterior clinodectomy to get space, enough space to the aneurysm. So this is also preparation of the internal carotid artery bifurcation, the A1 optic nerve. You can see here the previous bleeding. This is the contralateral optic nerve. This is the posterior clinoid on the right side. And this has to be taken away to get more space to the basilar artery, which you can see here. So this is the posterior clinoid, posterior clinoidectomy. And this is the basilar artery. And this is the aneurysm sac. What I'm preparing here is the superior cerebellar artery. And this is the posterior cerebral artery. And this is the aneurysm sac here. So my idea was to clip the aneurysm with a curved clip. So this is the view. This is the aneurysm sac, superior cerebellar and posterior. This is the preoperative or pre-clipping intraoperative angiography. And as you can see here, this is the superior cerebellar artery and this is the posterior cerebral artery. So this is also, I checked with endoscopy. This is the pipeline in the internal carotid artery. And in this case, I put in a retractor. I don't like general retractors, but this case was, it was for me safer to put in a retractor. And you can see the basilar artery here, the aneurysm sac here, the posterior cerebral, the superior cerebellar artery. This is the head of the basilar artery. And this is actually, this is the perfused part of the aneurysm, which you could also see during the intraoperative angiography. So also looking underneath the basilar artery, these are the perforators. And just to get an idea how to clip it best, I also thought of an fenestrated clip, but this was, I think, not possible to put it to come from underneath. So this is so until here, everything went according to my plan. So this is temporal clipping of the basilar artery. And now I try to clip. You can see here, this is the end of the clip. So I went also preserving the thalamo-perforating arteries, which I identified previously, and then closing the clip. It was a bleeding, removing the temporary clip, bleeding increased. Of course, in this situation, it was the catastrophe began. I would say I removed and put the clip again, but no chance to get this. There was probably a tear in the distal part here. So I'll put another clip, a longer clip to get this the solution. And finally, I had to clip both, also the cerebral posterior cerebral artery with the aneurysm sac, and then the bleeding stopped. So this is the intraoperative angiography. The superior cerebellar artery is still patent, so it works. And then the next step, I took away the large aneurysm sac to get a decompression. This was also an argument to proceed for surgery, to get a decompression, especially in the midbrain. And this is the final view before closing. So it looked okay, and I was optimistic, actually. So this is the CT scan on the first postoperative day. I was, of course, expecting a posterior cerebral artery infarction. So this is the clip here. This is a beginning demarcation of the posterior cerebral artery infarction. And this is the second day. You can see the demarcation of the infarction. I'm not sure if there's already midbrain infarction, because, as you remember, the aneurysm was entering the midbrain. So this could also be this site where the aneurysm was, or the aneurysm sac was entering the midbrain. So this is on the 7th postoperative day. She got an additional hyponatremia, which was not detected early in the intensive care unit, unfortunately. And this is, of course, a global brain edema, and I lost this patient on that day. Yeah, that's was the case. So what are the thinking discussion points in this case? Was the initial treatment appropriate? Should it have been treated as performed by interventional neuroradiology, or should have been a surgery performed? Of course, especially in Europe, we usually vote for interventional neuroradiologists in the basilar artery aneurysm. Surgery is not in favor in these cases. Usually the interventional urology is taking part, or is treating the basilar artery aneurysms. So was then, when the aneurysm recurred, was the treatment still appropriate with coils, as has been done in 2020? Was my surgical indication correct? Alternatively, of course, in retrospect, would have been the combination of flow diverter and surgery, or second surgery to remove the space occupying lesion, would have been an alternative. Actually, I consulted the neuroradiologist before, and together we made the decision for surgery. Was the clip and clipping technique appropriate? Actually, I have got even after again and again looking at the clip, I have no other idea how to put it. And of course, the cause and role of final fate of hyponatremia. I think this played a large role because the posterior cerebral artery ischemia or even larger infarctions can be survived. And I think this played also a major role. It was, we discussed it with the intensive care doctors, and I think this was a final hit for the patient. So René Leriche said something, some points I just want to add. He did not also only say the often quoted to visit your own cemetery, which I, with this case, visited. But he said also in this in his Philosophie de la Chirurgie, said very important points in my view, which actually we see today. You should talk to the patient. You should not just, as is the case in nowadays more and more, you should not take it only as a technical problem, but you have to deal with a human being and also with the relatives, and you have to talk to the patient. You have to examine the patient personally. I did this in this case, talk to the patient. Of course, this was a bit difficult. She was not in a very good condition. Talk to the relatives, and we together made the decision. And of course, also performing surgery. Should we perform surgery? Should we go switch to alternatives, alternative treatment? I cannot actually answer it clearly for this case I presented. Yeah, so that's the case. And thank you very much for your invitation, Dr. Sam, and I'm open to any question and discussion. Thank you very much.
Thanks a lot, Professor Hisham, for your excellent presentation and for sharing with us this interesting case. I see Professor Marcus want to ask something. Please go ahead, Professor.
Hisham, I feel with you. It's tough. You did a very nice technical job. Just a couple of questions, just so I understand the case fully. Was there, you said there was a pipeline in it or an enterprise stent or no?
No.
What was in it?
Yeah. The pipeline was actually in the internal carotid artery, for treatment of other aneurysms. It was not in the basilar artery. This would have been an alternative, I think, or I could have thought of. Of course, in retrospect,
right.
You're always. I would have wished to do it with interventional neuroradiology and put a pipeline or a flow diverter in it. It could have been safer.
So okay. So no, let's. I mean, that's another conversation. My partner in endovascular probably would have found an endovascular way to do it, but that's okay. But that's a different point. But let's say we're doing it technically. My only comment is when you put a very nice exposure you got your temporary clip on the basilar. Did you put a temporary clip on the contralateral PCA as well, or before you clipped the aneurysm?
No, I didn't.
Yeah, no, I probably would have done that, and also would have actually cut into, after temporary trapping, would have cut into the aneurysm distally to untether these thick walls. Obviously, as you said, when you close the clip, because it's thick wall, it sheared at the axilla of the PCA. So I sometimes even do adenosine in addition to temporary, just to soften everything. because the time of maximum risk of a tear at the neck is while the permanent clip is closing. So I don't know if you would have worked, but that's the only thing I would have done technically different than what you've done. But very tough case.
I think the clear lesson, of course, we know theoretically, but I think in this pre-treated aneurysms, because several interventions, the walls are not compliant anymore. So the lesson would be either you treat it completely by interventional neurology. It was actually treated in Miami before, but not in your institution. But I said Florida, but it was in another institution. It was not in University of Miami. I think so. For the neurosurgeon, I think you in these large and non-compliant aneurysm walls, where also you have the coil package close to the neck. I think these are the very dangerous parts, because the wall is thick and non-compliant, so it can tear while closing the clip. That's the lesson retrospect again.
Yeah. And also, besides, it's a fascinating topic. I've always been interested in this topic. The other thing is calculating the geometry of, the fundus to neck ratio, whether when the two walls come together, is there enough wall to come without tearing? It's a very interesting concept.
Theoretically, I would have put the clip, along the basilar artery, because this would have less stress on the. But this was technically you have to use a long clip. Sure. You have the brainstem on one side. You have not enough space, so this it would have been better, but I could not get a solution except the one I used.
The other thing is cotton clipping technique. I don't know if you tried it on other cases, but I don't know if it would have saved the day here. Published by Dan Barrow and Spetzler to insert a cotton to increase the surface area. I don't know if the tear was too strong to be fixable with cotton. It would have been worth a try also.
Yeah. Still hurts.
Of course, we're feeling it with you. This is not criticism. This is discussion.
No. It's that's why I'm presenting. I'm really open to have a solution. Unfortunately, I could not get the original ones. I talked to the relatives just in the morning if they could but it's too many CDs and they could not transfer it. I would have liked to maybe on another occasion to show the whole case also from the original point, because it was growing also on the MRI, and it should have had another solution before being such an complicated case actually. Thank you, Jack.
Thank you.
Okay, Professor Lou has a comment. Please go ahead.
Yeah, Hisham, thank you for sharing that challenging case. I was wondering if I noticed you had done a nice thrombectomy at the end of the case, and I'm of course hindsight is 20/20, and doing an MCA is different from a deep basilar location where exposure is much more difficult. But did you consider maybe in retrospect doing the thrombectomy before applying the clip so that you have more compliance? And the second thing I wanted to share was if the bleeding from the P1 was a small pinhole, maybe you can try taco seal, which I've repaired A2 injury before, which with some success.
I thought of to begin with your second question. I thought of taco seal, but it was too strong. It was not a small tear. It was not just to put it and compress it and wait. It was not the case. I thought of doing a thrombectomy before, also to get it more compliant. But I was afraid if I would do the thrombectomy, I get also a bleeding before, because if it would have be effective, the thrombectomy, you have to get to the neck. You have to release the widening, what you see on what you can see on the 3D angiography. There was actually a spanning of the aneurysm from the coils. So you have to get to the neck, and I was actually afraid to get a situation which I cannot handle in this case. Yeah, this was my thoughts.
Okay, thank you. Professor Oya, please go
Yeah.
ahead.
Well, thank you, Dr. Bashani. Thank you for sharing your painful experience. And first of all, I think I can understand how you feel, especially in such a short period after your surgery. And my question is about the a kind of not relevant to the vascular aneurysm itself, but you touched the ICA previously treated by the pipeline, right? Yes. And to create the wider space behind the ICA, I think you have to touch or mobilize the ICA a little bit with your suction tube or something. And how did it feel? You feel some resistance because of the pipeline, or it's still soft?
Actually, of course, it's not the first case with a pipeline treated or pre-treated aneurysm. To tell you my true feeling about pipelines, I'm always getting a shock because it's a very rigid tube put into a normal artery. So actually it is, and also if you've seen in the video, I got a bit with the retractor, I also pushed it away. So it is actually a rigid tube, and I'm quite astonished, how to put a rigid tube in a soft arterial wall. But it works, I know. So it is just the impression of me as a neurosurgeon. When I see these cases, I'm always astonished. Actually, also I'm a bit questioning if particularly in the basilar artery and also in the internal carotid artery bifurcation, these are often treated by pipeline and coiling, but I've seen a lot of recurrences of aneurysms, and these aneurysms are complicated. So I think they should also be strongly discussed as surgical cases, not neuroradiological cases. The tendency in Europe, at least, is of course to perform neuroradiology, and this is a great technique, of course. I'm not denying, but you see all along, you see recurrences and the aneurysms, as in this case I showed, and then there are others. They're getting more and more complicated, and they're putting coils, pipeline, and so on. So it never-ending story, and the aneurysm actually gets bigger and bigger and more complicated. So this was an extreme case, but there are others. I think you also got this experience and others that from more simple, of course, all these cases are complicated, but from a more simple aneurysm to a really extreme, difficult and technically demanding case. So this is what I've seen over the years with this technique. It is a wonderful technique. If it works, it's perfect. But I think the recurrence rate is underestimated.
Thank you very much. Thank you for your showing. Yeah, thank you.
Okay, thank you. Is there any question from panelists? Thank you, Professor Hisham, for sharing with us this amazing case and for discussion. And now we will shift to next speaker, Dr. Carolina. Please start sharing your screen. Thank you.
Hello, everybody. Thank you for this opportunity. Let's see if I can share my screen here. Actually, let me go to the beginning. Okay, can everybody see that?
It's okay.
Yes.
Perfect.
So I'm Carolina Benjamin. For those of you who don't know me, I'm one of the skull-based faculty at the University of Miami and Jackson Hospital Systems here with Jacques Morcos. And fittingly, I actually had entitled my talk, the title of the paper that the opinion paper that Dr. Morcos just published for Give and Remember. And I think that's a tremendously informational paper that all young faculty and all faculty across the board should read. But in particular, it addresses this concept of how complications can affect you early on in your career. And, you know, it allows you to learn from not only your own lessons, but also lessons of those of us who've gone through this before. So I think both forums such as this one, as well as opinion pieces and some of those publications can be really useful. So today I'm going to share a case that was a complication that occurred that I sort of went through it was a few months ago, and certainly it's still very clear in my mind, the events of that, and I think about it often, and I've learned a lot. So hopefully you guys can learn something from my mistakes as well to prevent that in the future. So 54-year-old male, history of alcohol abuse with cirrhosis. He presented to the hospital with complaints of blurry vision. And then he said, you know, perhaps some visual decline, right worse than left. On exam, he had a partial third nerve palsy, 20/150 on the right and 20/30 on the left, as well as bitemporal field cup. Ophthalmology evaluated him, no papilledema or optic nerve pallor, and we obtained some imaging. You can see here, this is a post-contrast MRI axial on top, and you can see this extensive extraaxial tumor involving encasing the carotid and extension into the optic canals, particularly on the right, and also with invasion into the cavernous sinus on the left. And so this was a pretty extensive tumor, and you know, we thought this was going to be pretty much centered on the tuberculum, but because of its extension, its lateral extension beyond the extent of the carotid, I think I have a sagittal here on the next one as well. So if you look at just the sagittal, you know, perhaps you're thinking that an endoscopic route would be good for this, but the key things to remember here, you know, there's significant encasement of the anterior communicating artery and its branches, and there's also very lateral extent. You can see here on the coronal that extends lateral to the carotid, and you know, therefore we always consider an endoscopic approach versus an open approach, although there are different beliefs of whether or not tuberculum cell meningiomas should be tackled through the endoscopic route. That can be a satisfactory approach in some cases, but not in a case like this with significant vascular encasement and also lateral extension of the tumor. So this patient actually, at the time, this came in under Dr. Morcos, and we tackled this together. And he underwent frontotemporal craniotomy for resection of this tumor, Transylvian approach. The surgery went uncomplicated. He did very well from the surgery. You know, there's lots of motion artifact, but we sort of accomplished our goal here, which is we decompressed the right optic nerve. You know, we knew from the beginning that the component in the left cavernous sinus was not going to be addressed neither in the surgery nor was that our goal. So we felt that we had achieved our goals here. So his right-sided vision improved, his field cut improved, clearly had the continued third nerve palsy on the left side. And the pathology actually came back as a grade 2 meningioma. There was significant, I don't have a T2 up on those images, but there was some brain edema, and the tumor was very invasive into the brain. So the pathology came back as a grade 2 meningioma. He was discharged to rehab, but unfortunately was, not a great, not great in terms of follow-up. So when we set up his appointments to come back, we never saw him back, and he ended up presenting to the resident clinic 2 months later after being lost to follow-up. So I think an important thing, we knew he had that residual component in the left cavernous sinus, and the thought that was that we could do gamma knife, irradiation to that left cavernous sinus component. But again, we didn't have good follow-up on this patient. So that's kind of a setup for disaster. You're leaving tumor behind, and some of these grade 2 meningiomas, not all of them are aggressive, but certainly if you leave gross residual disease behind, you have to consider alternate therapy for that. And we weren't able to do that due to this. So one important lesson, it's not just about doing, very nice surgery to begin with, but you also have to continue to care for the patients, and that postoperative care is just as important. At this point, when he followed up, when he finally came to our clinic, he was blind on the right side. Vision on the right side had declined. Vision on the left also declined. And now he had a cranial nerve 3 and a cranial nerve 6 palsy on the left side. Okay, so obtained some imaging at that point, and you can see there's significant recurrence of this tumor. And you can see that cavernous sinus component is more severe. There's, tumor back on the right side. So this really has just progressed in all directions. And so the plan at this point, he had no light perception in the right eye. So the goal really was to decompress the vision in his only good eye. And so that was the plan. And, I started to set him up for an endoscopic approach to do decompression of that left side. In the meantime, he was admitted to the hospital and in status. Okay. He had never had a seizure before, but he developed status a month later. He did have, after the first surgery, he did have issues with panhypopit. So, he also was hyponatremic. So I think that also contributed to this. The thought was the hyponatremia induced the status. And once he was stabilized on 2 anti-epileptic medications, we had a plan for surgery. So another important thing here is, you have to be careful. Again, the care of patients like this who can become panhypopit, that's a complicated patient, and you really have to be careful. Things like hyponatremia can really cause the seizures, and this is all just sort of indicating this is a bad tumor. This is acting as to the patient. So 2 weeks, so he was discharged home after the status, and when he was came back in to the ER again, saying my vision is getting even worse. Another image was obtained, and again, this tumor just continues to grow, and it's at this point very invasive. So there's again encasement of the MCA and the ACAs here. There's significant involvement of bilateral cavernous sinus. There's tumor in bilateral cavernous sinus, certainly left worse than right. And then there's a significant component here hanging down in the sphenoid. So I looked at this imaging, and, my goal still continued to be one thing, which is to try to save his only good vision, his left-sided vision. I was not, I thought I could do this through an endoscopic approach. The goal was not to get this component that was all encased, where all the vascular encasement was. And my goal certainly was not to address any of the cavernous sinus component. Okay. And before this, actually, I had met with, finally, his family began to come to his, to accompany him. And I explained to the family that the importance of, if we do the surgery, then we really have to have you guys follow up, and we need to do postoperative radiation. This is not a one and done sort of deal, and this is something that's going to require chronic care. And as we know, some of these meningiomas really are difficult to manage tumors with no medical options to really help you in any way. So, I did an endoscopic and a nasal approach, and the case went fine. The tumor was firm. I could get a plane along bilateral cavernous sinus. I could see exactly where the borders of the cavernous sinus was. And I did not try to address the tumor that was causing compression on the right optic nerve because he was already blind. I wasn't going to make any difference there. My goal was really to decompress the nerve on the left. And when he woke up, he still had slight improvement, but his vision was still blurry. And the post-operative imaging, so you can see here that, again, I got to the borders of the bilateral cavernous sinus, was able to decompress that. But there's this small component of tumor you can see very nicely here on the T2 that was causing compression, continued compression of that left optic nerve. I thought that this was problematic for multiple reasons, most important of which is if the goal was to preserve his only good vision, then we had not accomplished that goal, number one. Number two, this is a grade 2 tumor and leaving gross residual disease behind. We were not going to be able to give any stereotactic radiosurgery, and we were going to be limited in our radiation options. So I actually discussed with my radiation oncology colleagues too, the options for radiation. And they said, well, we can fractionate it. The problem with that is that for the grade 2 meningiomas, it's going to be limited in its efficacy in terms of stopping the tumor. And, there's a good chance he'll also go blind. So I discussed this with the family and I discussed this with the patient. And I said, well, this is what we have, in terms of the options are to go back and try to get that small piece that's just causing the compression on the left optic nerve or we can try the radiation. And they said, okay, no, this is his only good eye. And let's try to go back. And I said, okay, that's a reasonable approach. If you can actually also, the only other thing is you can tell that there's some extension here of the tumor almost starting to get into the posterior fossa here. And I was able to address that to some degree. But my goal really wasn't to get this tumor. I didn't want to even think about getting into the posterior fossa, into the basilar or any perforators. So this was really, I stopped where I think I wanted to stop in the posterior extent as well as the lateral extents. But again, this small component in the left optic nerve was problematic. So intraoperatively, I unfortunately, and I'll go through this again a little bit later, but the video where the complication occurs, it's not filmed. And the reason is that as soon as the complication occurred and things got under control, I said, hey, can somebody make sure we're recording this, right? Because we want to be able to learn from our complications. And I think it was recording and the person turned it off as opposed to turning it on. So I have some pictures, but I don't have the video of the actual complication happening. So this is the optic nerve on the left, and I was able to get all this tumor out. And importantly, when I looked back, I actually had noticed this beforehand. You could tell that the ophthalmic branch coming off of the carotid was involved in tumor. And I could tell that from the preoperative imaging. And I could also tell that as I was working, I could see the ophthalmic, I was able to see it very clearly. And I could tell that it was completely encased in tumor. So my goal was really not to try to get a complete resection here. My goal was really just to decompress this. And I actually opened this optic nerve sheath a little bit further, and I was trying to just create enough space to be able to give ourselves room and to be able to radiate this postoperatively. And as I was doing so, I essentially, this was me using a small round knife, and this was fine. But when I actually grabbed a curette, like the Roten 14, not a curette, but a Roten 14 type instrument, and I think as I just pulled this down, the ophthalmic avulsed off of the carotid, and I got brisk arterial bleeding. And all of the bone at this point had been drilled away, so I didn't really have any bony landmarks where I could really put pressure. Anytime that I stopped, that I took the suction away, to try to see where the bleeding was coming from. Was there a pinpoint area that I could use the bipolars? It was just significant bleeding, and I wasn't able to visualize that. So at that point, I waited for, I asked, my resident who was working with me to give me some muscle. And interestingly, the crushed muscle was what worked the most because, when I had my instrument, once I got the injury, when I had my instrument pushing it down, the bleeding would stop. But anytime, even if I put a cottonoid on there, it would continue to bleed. So it wasn't until I got the crushed muscle there that I was able to get the bleeding under control. A couple of lessons I learned from that intraoperative day. First off, you really do set the tone, and I think I've discussed this with Dr. Liu and Dr. Morcos. It almost felt like an out-of-body experience because you're prepared for something like this. You're prepared to handle a complication. You know all the steps, and it is really important to keep your calm. And and one of the benefits too is that the optic nerve had been decompressed. So I was actually able, when I was able to put my instruments on the bleeding, I pushed down as opposed to pushing up, right? Because I was worried about causing injury to the nerve. So finally put the muscle on there, and you can see here I packed it in with some cottonoids, and then on the way up to angio, I inflated a Fogarty balloon just to be sure that we had good control, and took this up to the endovascular suite. You can see the angio here, and you can see that there's some thinning here of the A1 segment. And I think, at this point we had a lot of, we had the packing in place, and we also had the balloon inflated. So I think that was contributing a little bit to the stenosis that we're seeing here on the angiogram. And on the right side here, you can see that there's a venous delay. Doing a carotid occlusion at this point would not be great. But, because there was compression on the, from the actual mass of the Fogarty balloon and everything else, I actually brought up my endoscopic tower to the angio suite, and under direct visualization, I deflated the Fogarty balloon and I took down all the packing, to be able to see where is this coming from. And my endovascular colleague who was with me at the time, he said, I'd like to see if I'm able to get there, and they'd like to put, a stent in. So they were trying to put a stent that they actually use in cardiac, and he's used this a couple times, and he says it would be really nice if I could get that in there. So we tried to do that. Unfortunately, he was not able to stent across this. He couldn't get the wire. It kept on going. He thought it was going in the subarachnoid space. He really didn't think that it was going in the right space. But you can see here, obviously, an injury right at the ophthalmic takeoff, exactly as we thought, causing extravasation of contrast into the sphenoid here. And so at this point, we discussed our options, and I asked him, is there any way we can try to stent across this, and unfortunately, because he was not able to do that, he said, we're going to have to just take the carotid. So I said, okay. So we had to do that, right? So he took the carotid here. Interestingly, he thought that if he, rather than, you can see that he took the carotid down here as opposed to taking it right at the site of injury. He thought that if he started to put the coil mass close to the site of the injury, the issue with that would be that he thought we were going to get too much mass effect, kind of like how we got mass effect from the packing beforehand. He thought we would get mass effect here on the A1, and that was going to cause an issue in terms of perfusion of that hemisphere. So he took the carotid with some coils, and you can actually, interestingly, that stenosis of the A1 improved once I took down all the packing and the Fogarty. And then also there was some venous delay, but it was improved compared to that initial angiogram. So, I was hoping, and mind you, at this time we were keeping I was not pushing the blood pressure yet because of, because of the carotid injury. And so I was hoping that with the improvement in the venous delay and these pictures here, that I could get away with perhaps pushing the pressures. The only issue with that, and this is what I told my endovascular colleague, was that the site of injury at that point was still not fully protected, right? And so I asked him, I was like, I'm going to be limited in how much I can push the blood pressure if the site of injury is not protected. But at that point I said, well, you know what, if it bleeds from the nose, I'll reinsert a Fogarty and do what I have to do. I think it's important to perfuse that hemisphere. And I got a post-operative MRI. You can see that there is a small diffusion hit there, but not terrible at this point. And he actually had a pretty good neurologic exam. And so at this point, I wanted to see what I had in terms of perfusion mismatch. And you can see that there's a large area of increased time to peak and mean transit time in the left MCA territory, as well as decreased cerebral blood flow in the left MCA, as well as especially in the left corona radiata. So again, this is showing, obviously, we've taken the carotid, and then you have some watershed ischemia as well. So this was a combination of factors, and I thought that I pushed the pressures, and I was pushing the pressures. He wasn't bleeding from the nose, so I was safe from that standpoint. But I still thought that there's still significant perfusion mismatch. So I discussed the case with Jacques, and I said, "Hey, I think we should do a bypass. Can you help me with this?" So Jacques was actually out of town. He came back in town, and we reviewed the imaging, we reviewed the case. And I think another lesson here that I didn't necessarily write on this PowerPoint, but I think that's equally as important. I think it's critical, especially for junior faculty starting in skull base and vascular, to really have a senior partner with whom you can trust and whom can help you and is willing to help you, at the time. And I have to, give Dr. Morcos full credit. He never questions, he never tries to make you feel badly, and he just tries to help the patient. And I think that's the most invaluable thing I could ask for. And I'm very lucky to have that. So I think if you can find yourself in a situation, in a job where you can have that, then do so, because it's critical. So the plan was to perform an STA-MCA bypass. Another important lesson here is that, again, skull base and vascular are intimately intertwined. Dr. Morcos gives a talk about how they are the inseparable twins, and I think this is the perfect case to illustrate that. Prior to, so the plan, this was the day before, I was planning on doing the STA-MCA bypass. This was on a Saturday. We were planning to do it Sunday morning. I went and I rounded on the patient Sunday morning, and the patient had a very severe deterioration in the neurologic exam. He was no longer moving his right side. And so I talked to the ICU and I said, "Hey, what happened?" And it turns out that overnight, there was an ICU fellow. The patient had been on 2 pressors to keep his blood pressure up, and one of the fellows actually discontinued one of the pressors. And so this guy was getting actually only dobutamine and not just alpha and not beta. And so then what happened is that he essentially stroked out. His blood pressure at he was hypotensive to the systolics in the 90s for a good period of 2 hours overnight. And so when I came and saw him and I saw that his neurologic exam was worse, I said, "Well, hold on. We got a CTA-CT perfusion." And actually, Dr. Morcos and I were talking about it. We're like, it's not so bad. Let's do the bypass. And we were prepared to do the bypass. And I said, while the OR gets set up, why don't I just get a quick MRI? And that's just a diffusion sequence MRI. And so we took the patient down for this MRI, and you can see that he had a much larger infarct. And so I think a couple lessons from this is, number one, don't just look at the imaging. If we had based it off of just the CTA-CT perfusion, we might have gone forward with the bypass. And if we had done that, we likely caused a hemorrhage and made the situation worse. So the importance of the neurologic exam: trust yourself. If there's an exam, get more imaging, convince yourself. And also the importance of, once you have a complication, really think carefully about what your next steps are, because you can always make things worse. And so you have to really critically evaluate each step once that's happening. And it's a complex situation because you're already stressed from the original complication. So you have to, again, ask for help, or just really be very rational when it comes to the thinking of what the next steps are to fix your mistake, because the last thing you want to do is make things worse, right? The last thing we want to do is do a bypass and then have the patient wake up with a large hemorrhage and complicate our own complication. So the patient actually, so after this, the patient, he had his exam again. He was plegic on the right side. The issue became that he also went into severe heart failure, which was very, very hard to manage. And he went into multi-organ failure. I spoke with the family at length. I visited them with them, and I showed them every single image. I showed them all of our thinking, and I was very clear with them. But once, you know, he went into multi-organ failure, the family said, well, you know, he's going to be, if he's going to live a life where he's hemiplegic, possibly aphasic, and possibly, you know, we don't even know what the vision situation is on the left side. He's blind on the right. He would not have wanted to live this way. And so they chose to withdraw care, and he expired. So this was a very tough case. I think there were many, many lessons along the way. I looked back, one thing that's of note, the pathology actually came back grade 3. So this was actually a meningioma that was pretty aggressive. It was at grade 2, recurred in a matter of 2 months. And then in a matter of 4 months or 5 months from the original surgery, it already had, was a grade 3 in aggressiveness. So this was a bad tumor to begin with, right? And I think a couple of things pointed that to me, which was the time course of the events, how significantly clinically affected the patient was, you know, the fact that he became hyponatremic, had this episode of, you know, of status, all these things point to a very aggressive tumor to begin with. One thing was, you know, your indication for surgery. I thought about this a lot of times. Is there something I could have done? Could I have just radiated? I definitely discussed it with the radiation colleagues. I think my goal was to try to preserve his vision on the left. He was clear that that's what he wanted. I thought it was indicated, but certainly that's another, you know, that's one thing that you have to look back was, should I have been here to begin with? And I think, you know, that was at least something I told myself, well, I think my indications were at least valid. My goal for the surgery was very clear. I was not trying to go for broke. I was not trying to get the portion of the tumor that was encased in all the vasculature. I was not trying to get into the cavernous sinus. I was really trying to decompress that left optic. Also, when complications happen, you know, take a breath, because you set the tone in the OR, and that can be difficult if it's the first time you're experiencing complications, especially earlier on in your career. But it's critical, and it can lead to a much better outcomes. And then honesty and communication with the family, that ultimately is critical. That you know, these are the patients that you have to, that are difficult to go in to see, and you have to go see as much as you need, as much as they need, because that's all you can provide with them for the family at that point. I do believe, and I do really agree, that skull base and vascular are the inseparable twins. That I agree with Dr. Morcos on this, and I think this is something for our entire specialty to think about, because more and more as the, you know, endovascular becomes a growing field within neurosurgery, you know, people are sort of, you're segregating into either skull base, where you're doing open skull base and endoscopic skull base, and vascular, where you're doing endovascular and open vascular. And, you know, the skull base surgeon who's able to do skull base and open vascular, but not do endovascular, is almost like a dying breed. And should that be the way it is? Should we be continuing to endorse that, or should we really be endorsing that the skull-based surgeon really should be able to manage all vascular complications? And I think, you know, if you go into academics, at least here in the US, you're really pushed to hyper specialize. And so I think the skull base and vascular area is becoming less and less common. And then I think, you know, other people talked about this, determine what type of error it was. Was it the wrong instrument? Was it the wrong move? Was it like Dr. Like Diego said, you know, is this an anatomy issue? Were you lacking in the knowledge of anatomy, in really sort of determine where the error was in order for you to be able to fix it? And then review the videos. Again, perhaps don't say, is this being recorded? Because then the video doesn't get recorded, and that's important. It would have been nice to review that for me personally. Restudy the imaging. Could you have known more about the subtleties of the imaging? And then don't base your next surgical decision on your last mistake. You know, each case is different, and you must learn from each case, but you can't really make one decision based off of a mistake, because that's acting more on the emotional end as opposed to on the rational end. Remember the losses, but don't forget to also celebrate the wins. We're here just to talk about the losses, and we have full conferences about losses. And I think it's equally as important for us to remember, you know, when things do go well, and celebrate the wins. Thank you very much.
Thanks a lot, Dr. Carolina, for this excellent presentation. Is there any questions from panelists?
Thank you for sharing that
Okay, yeah,
case.
no.
Oh yes, thank you for sharing that case. When you mentioned that you came into the ICU the next day and the fellow managing it had stopped the medication, I can almost relate to that. It's so many instances where, you know, part of it was we have to trust other members from other teams, and you know, I just wanted to ask as to how you sort of process that, and in terms of like, you know, in retrospect, what was the communication to the on-call team, and
Yeah.
sort of going forward, how you've handled these kinds of things.
Yeah, so interestingly, that's a great point, and I think it's underestimated. You can't be everywhere at once, right? We are in the operating room, and you can't be managing the patient on a second-to-second basis. I was rounding on this patient multiple times a day, and so it was Saturday. It was our graduation, and I actually was late to our graduation by about an hour because I decided to go back into the hospital to sign out to the overnight team. So I personally gave my cell phone number to the nurse, to the fellow, to the ICU resident, to like 3 or 4 different people. And this was at about 6 or 7 p.m. at night, the night before this happened. And I said, if this person, the exact words I used was, if this guy even coughs wrong, call me, like, please. And nobody called me. You know, I checked in after graduation. I called to the ICU it was around maybe midnight or so. I called and I checked in, things were stable, he was doing okay. And this happened around 2 or 3 in the morning, and I was not informed. And I discussed with our critical care team and the attending who was on call. He said he was not called, and they discussed it. I asked them to please review it in there. I don't know if they have M&M, but I said, if you have some sort of forum where you guys review it, I think it's important as a learning point for your trainees. And he said that they would. I trust that they have, and I hope that they have, because I think, again, we're all teams, and we have to depend on other teams to help us with this as well. So it was sort of the perfect storm of a lot of negative events that led to this complication. And I certainly have learned tremendously from each of the steps.
Maybe I can just add something. If it is a fault of some of the participants in the ICU, we have got an anesthesiologist, or the anesthesiology is running the ICU in my institution. But sometimes it is also another philosophy. For example, if the patient is old, you're fighting with the patient, you know from your neurosurgical experience that even if it looks bad, it might have a very good outcome. And but the people who are at the bedside, and even also the anesthesiologists, your colleagues, they see, well, there's no chance, patient is old, so they are actually I won't say intentionally, but even if you're thinking it has a bad outcome, so your philosophy is directing it into the wrong road, actually. So this is often a problem in my institution. And as you said, you cannot be always at the bedside and seeing what is going on. You cannot handle every drop in blood pressure which is needed for a good outcome. So this is this is also a problem. Not the obvious faults as you described it, but also the philosophy which is different from the surgeon, he is actually more involved with the patient's case, with the relatives, who has talked to the relatives, who has also a load. You are responsible for the case, and this is might also influence outcomes. And this happened several times. I cannot solve it, but it's a problem. Thank you very much for your interesting case.
Thank you.
And very, very important point you mentioned at the beginning. I forgot to say it in my presentation. You have to be responsible for the patient. We all like to, sorry, we all like to do nice surgeries. So I think this is a common in every surgeon. We want to make the great cases and so on. But very often nowadays, you are not interested in the patient after your surgery. And I think it's very important, especially in neuro-oncology, that you follow up the patient, because and also long-term follow-up. And especially in the meningioma cases and the great ones, especially skull base, the recurrences will come after years. It's not after 1 year, after 2 years, not after even 5 years, but after many years. So I think it is very important and to follow up the patients for years. And then there are several also opinions that you can stop imaging the patient and follow up after, for example, 5 years. But actually the recurrences may come later and you will not detect them. And you have to learn from these cases. And I think it's very important that you as a surgeon personally follow up the patients whom you operated on. So I think this is very important. And I think this tradition or this is lost a bit, because if something complicated comes, you're not responsible. If it's your own patient and you want to make the next interesting case, you lose about the last one. So I think this is very, very important for learning for yourself, quality also management and quality responsibility.
Yeah.
Thank you.
Okay, is there any question? Thank you, Professor Carolina, for this excellent presentation and the good discussion. Thank you for sharing also this interesting case with us. Is there any comment before we close this session?
What's that, Sam?
Okay, okay, John, go ahead.
Oh yeah, great learning experience. Thanks, everybody.
Thank you for organizing.
Thank you guys very much.
Thank you.
See you in the next one.
Thanks a lot, dear professors, for joining us today. Thanks a lot, dear participants, for joining us today. It was many lessons that we have learned today. And I think the best lesson that we have learned is that you are not a hero. You have to study your cases well, and you have to study your team capabilities and your facilities. You have to take care to every step before you go to your surgery, and every step in it, then post-operative care. Thank you.
Thank you.
Thank you very much. Too interesting.
Thank you again. Thank you. See you soon.